Okay. Hello. Okay. Sorry, there was no audio. Hope the audio is fine now. So once again, hello everybody. Hope all of you are doing fine. Your preparations are going well. See, however, your INS set exam has gone. You have seen the result, whatever it is, whether it is good or bad. No need to think too much. Now, if you keep on thinking whatever has happened, right, further it is difficult to proceed. So I know it is very difficult to remove whatever has happened if the result was not good, but still you have to make your mindset strong not to think of the results of INS set and further continue the preparation for the NEET exam. So today we are going to discuss the important topics which have appeared in the previous exams, like 3 to 5 years exams, right, NEET exams, so that we can prepare well for the NEET exam, the upcoming exam. With that, let's begin with the first topic. The first topic is sterilization and disinfection. You know, that is a very important topic. That is a very important topic from general microbiology, right? From general microbiology. इंतहा हो गई इंतजार की. Okay. So with that, now if you talk about the sterilization and disinfection, the three important questions which are very important is: one is endoscope sterilization, second is blood spill management, and third is culture media. You know, endoscopes are sterilized by glutaraldehyde. If glutaraldehyde not there, orthothiol. If orthothiol is not there, then H2O2, which is also known as plasma sterilization. And if that is also not there, ETO. That's how you have to answer. Those are the preferred methods, right? These are the preferred methods, and question will be based on preferred methods only. Question will be based on preferred methods or most commonly used methods. So similarly, if you talk about the blood spill management, 1% sodium hypochlorite is the answer. And if you talk about the culture media, for most of the culture media, we have to use autoclave to sterilize, except serum and egg containing culture media. For serum containing media like low flow serum slope and egg containing culture media like LJ media, we have to sterilize by either inspiration or tyndallization. Both can be used to sterilize serum and egg containing culture media like LSS and LJ media, but yes, preferred is inspiration over tyndallization. So these are the three important questions from sterilization and disinfection, right? And now moving on to the questions which have appeared in the previous exams. Right? So PDF will be provided or not? Okay, PDF will be provided. A patient met with a RTA, road traffic accident, brought to the emergency room. Patient expectorated blood on the floor, which is the disinfectant used to clean the blood spill. So question is based on the blood spill, and just now we have discussed here the blood spill is by sodium hypochlorite, and that's why the answer is sodium hypochlorite. Option is D. Very simple. Yeah. So if you talk about the next topic from general microbiology, that is morphology and growth. Morphology of the bacteria. Morphology means appearance, how the bacteria they look like. You know, bacteria are nothing but unicellular. They're made up of cell, right? Bacteria are unicellular. They're made up of cell. And the two important structures in bacteria, one is capsule. Capsule is not there in all the bacteria. In only few bacteria, capsule is there. And second important structure is fimbria. And third important structure is flagella. So these are the three important structures which are not found in all the bacteria. Then how will you come to know these structures are there or not on the bacteria? That means how can you detect these structures? That's the next question. Sir, answer is very simple. If you talk about the capsule, sir, we have two types of capsules. One is polysaccharide capsule and one more is polypeptide capsule. Sir, we have two types of capsules. One is polysaccharide, one more is polypeptide. Sir, polysaccharide capsule is found in pneumococcus, meningococcus, haemophilus influenzae B. And polypeptide capsule is found in latex agglutination test, negative staining, and McFadden staining. Sorry. Right? Sir, polypeptide capsule is found in only one bacteria, that is Bacillus anthracis. Right? Polypeptide capsule is found in only one bacteria, Bacillus anthracis, whereas polysaccharide is found in pneumococcus, meningococcus, haemophilus influenzae B, etc. But these are the three important polysaccharide capsule containing bacteria. And sir, polysaccharide capsule is detected by latex agglutination test, negative staining, and Quelling's reaction. Whereas polypeptide capsule is detected by latex agglutination test, negative staining, and McFadden's reaction. Sir, very simple. Sir, first two methods, latex agglutination test and negative staining. With these two methods, you can detect even polysaccharide and polypeptide capsule. Whereas the last methods, Quelling's reaction, you can detect only polysaccharide, and McFadden staining, you can detect only polypeptide. Now you know how can we detect capsule, whether it is polysaccharide or polypeptide. And you know which are the bacteria which are having polysaccharide capsule and which are the bacteria which are having polypeptide capsule. Very simple, capsular detection. So next, Fimbria detection. Sir, Fimbria is an organ of attachment. It helps the bacteria to attach, and it is present in all the bacteria which can cause UTI, urinary tract infection, because they have to attach to urinary tract to cause the infection. Otherwise, they will get washed away due to the urine action of urination. So that's why all the bacteria causing UTI, they have Fimbria, and Fimbria is an organ of attachment, and that can be detected by heme agglutination. The Fimbria agglutinates the RBCs. If RBCs are agglutinated, Fimbria are there. If RBCs are not agglutinated, Fimbria are not there, because Fimbria agglutinates the RBC. They are the organ of attachment, and they are present in all the bacteria which causes. They are present in all the bacteria which. Sir, will there be similar sessions of other subjects too? Yes, all the similar sessions will be there for all the 19 subjects. Right, very good sessions. I recommend everybody to attend. Right, not because I am there in this session, but it will be very helpful, not only for the students of Bhatia platform, any platform, any student all over India who is preparing for entrance exam, NEET exam. These sessions will be very helpful, fast, quick, and previous year topics and previous year questions are discussed. Anyways, sir, heme agglutination. Sir, Fimbria causes heme agglutination. That's how you detect Fimbria. Simple. Flagella is an organ of locomotion. Flagella is an organ of locomotion. Right. So now flagella is an organ of locomotion. So bacteria which are having flagella are motile. The bacteria which do not have flagella are non-motile. Right, non-motile. Very simple. Bacteria which are having flagella are motile. The bacteria which are not having flagella are non-motile. See, whatever questions are there related to sessions are there or not, whether it will be there in YouTube, we'll discuss in the last. First, we'll cover the topic related doubts. Flagella is an organ of locomotion. So flagella is there, bacteria are motile, flagella are not there, bacteria are non-motile. Simple. So the thick bacteria which are having flagella, right, these bacteria can be seen under bright field microscope. These bacteria can be seen under bright field microscope. As they can be seen, their motility can be seen. If they are motile, they are having flagella. Non-motile, they don't have flagella. The problem is with the thin bacteria. So thin bacteria are not seen under bright field microscope or light microscope. That is the normal microscope what we have used in physiology, pathology, microbiology in our first and second year MBBS. Bright field microscope or light microscope, in which you can see only thick bacteria. Therefore, motility of the thick bacteria can be seen in bright field or light microscope, and because of that you can identify the motility of thick bacteria. But whereas thin bacteria, it is difficult to see in bright field microscope. As they're difficult to see, when you can't see them, you can't see their motility. And that's why for thin bacteria you require microscopes. In which you can see the thin bacteria. So thin bacteria can be seen in dark field microscope and phase contrast microscope. These are the two microscopes in which you can see thin bacteria. As you can see thin bacteria, you can see thin bacterial motility. As you can see thin bacteria, sir, here you can see thin bacterial motility. Thin bacterial motility can be seen with dark field and phase contrast microscope. Again, among these two, which one to select? Yes, you have to select dark field. Remember, dark field is better than phase contrast. Dark field is better than phase contrast. And thin bacteria are nothing but spirochetes. Thin bacteria are spirochetes. Sir, spirochetes are the thin bacteria. Okay, thin bacteria are nothing but spirochetes. The spirochetes are the thin bacteria. And you know, spirochetes are the bacteria which are spiral in shape. And you know, the three bacteria which are spiral in shape are Treponema, Borrelia, and Leptospira. Treponema, Borrelia, and Leptospira. Treponema, Borrelia, and Leptospira. So with that, these three bacteria are spiral in shape. That's where the spirochetes, they are the thin bacteria, and their motility can be seen with dark field and phase contrast. Dark field is better than phase contrast. These are thin bacteria. Their bacterial motility can't be seen in bright field microscope. Bright field, you can see thick bacterial motility. And why we are seeing motility? Bacteria are motile, they have flagella. Non-motile, they don't have flagella. To identify flagella. So with that, this is about the another important topic in general microbiology. So that is capsule, polysaccharide and polypeptide, how to detect, and which bacteria they have, and Fimbria and flagella. Right? Fimbria is present in the bacteria causing UTI, and flagella is present in the motile bacteria. Flagella is found in motile bacteria. Which are the motile bacteria? There are many motile bacteria, no need to know. Just remember, flagella is present in motile bacteria, all motile bacteria. Fimbria is present in all the bacteria causing UTI, and capsule is present in 3 important polysaccharide and 1 important polypeptide. So in which bacteria are having these structures, and why do we have to detect these structures, and how do we detect these structures? Everything is explained. Right? Based on that, if you see the questions which have appeared in the previous exams. So a truck driver presented with painless genital ulcer on penis with enlarged lymph nodes. right? Remember, painless ulcer, painless lymph nodes diagnosis syphilis, right? Further we discuss in the genital ulcerative disorder, painless ulcer, painless lymph node syphilis. And syphilis is caused by the bacteria Treponema pallidum. Treponema pallidum. And sir, Treponema pallidum is a spirochete, which is a thin bacteria. Treponema pallidum is a spirochete, which is a thin bacteria. It is a spirochete. It is a thin bacteria. And if you see, the question asked is the motility, right? That is important. The motility of the organism responsible for this condition. The motility of the Treponema pallidum, answer is dark field microscope. Very simple. Thin bacterial motility. Right? Thin bacterial motility. So moving on to the next question. So now general microbiology is over. Moving on to the bacteriology. Moving on to the bacteriology. Sir, important topic in bacteriology, sir, bacterial meningitis. Sir, bacterial meningitis is a very important topic in bacteriology. Right? Sir, bacterial meningitis is further classified into acute bacterial meningitis and chronic bacterial meningitis. Acute bacterial meningitis and chronic bacterial meningitis. Okay, sir, acute bacterial meningitis is caused by pneumococcus. Acute bacterial meningitis is caused by pneumococcus. This is the first image. This is meningococcus. Meningococcus. This is the second image. Meningococcus. Right, and third is Haemophilus. Third is Haemophilus. So these two are Haemophilus. These two pictures are Haemophilus. So these are the three bacteria which causes bacterial meningitis, acute bacterial meningitis. So do not forget, acute bacterial meningitis is also known as pyogenic meningitis. That you should not forget, right? It is also known as pyogenic meningitis. Pyogenic meningitis. Yeah. Pyogenic meningitis is also known as acute bacterial meningitis. Pyogenic meningitis is also known as acute bacterial meningitis caused by three bacteria: pneumococcus, meningococcus, Haemophilus. So remember, pneumococcus is the most common organism causing meningitis, followed by meningococcus, followed by Haemophilus. Now pneumococcus. So pneumococcus is a gram-positive cocci arranged in pairs. Okay, it is a gram-positive cocci arranged in pairs. What you see here is gram-positive cocci arranged in pairs. Right? And meningococcus is gram-negative cocci arranged in pairs. Right? And meningococci is intracellular, present within the neutrophils. See, these are neutrophils. Those are dark pink color structures are nuclei of the neutrophils, and small pink color dots are, right, meningococcus, gram-negative cocci in pairs. So pneumococcus are gram-positive cocci in pairs. That's why you see violet color, round-shaped bacteria arranged in pairs. And meningococcus is gram-negative cocci in pairs. You see pink color, round-shaped bacteria arranged in pairs, and they are intracellular. Okay, meningococcus is intracellular, and that's why you can found within the cells. Which are these cells? PMNs. PMNs means polymorphonuclear cells, means neutrophils. Whereas if you talk about Haemophilus, sir, Haemophilus, right? If you talk about Haemophilus is pleomorphic organism. Haemophilus is pleomorphic organism. Pleo means different, morphic means morphology. Pleo means different, morphic means different morphology. Different morphology means, it appears in the form of cocci. You can see a round shape, pink color round shape. Okay, gram-negative pleomorphic. Gram-negative means in gram strain they appear pink color. Pleomorphic means they appear in the form of cocci, they appear in the form of bacilli, they appear in the form of cocobacilli. All the three morphological forms of the bacteria. So bacteria are either in the form of cocci, or in the form of bacilli, or in the form of cocobacilli. But Haemophilus is present in all the three forms: cocci, bacilli, and cocobacilli. Cocci means round shape, bacilli means rod shape, cocobacilli means oval shape. So that is what is pleomorphism. Pleo means different, morphism means morphology, different morphology. And second picture, what you see is satellitism. The satellitism is seen on blood agar. And these are gram stain pictures. This is also gram stain picture. This is also gram stain picture. So we have seen gram stain picture for pneumococcus and meningococcus, and for Haemophilus, gram stain picture and blood agar picture. On blood agar, you see satellitism. What is satellitism? You know, So the middle line, what you see is Staphylococcus aureus. Okay. So the middle line, what you see is Staphylococcus aureus. So this is Staph aureus. This is Staph aureus. And these perpendicular lines are Haemophilus influenzae. Haemophilus influenzae. Those perpendicular lines are, sir, Haemophilus influenzae. Sir, Haemophilus influenzae grow near to Staphylococcus. It will not grow away from Staphylococcus. That is satellitis. Haemophilus grow near to Staphylococcus. It will not grow away from Staphylococcus. That is satellitism. Right? That's how you can identify, sir, meningococcus, pneumococcus, and Haemophilus. So these are the three important bacteria which causes acute bacterial meningitis. Coming to the chronic bacterial meningitis. The chronic bacterial meningitis is caused by Mycobacterium tuberculosis. Right? Chronic bacterial meningitis is caused by Mycobacterium tuberculosis. And you know, Mycobacterium tuberculosis is acid-fast bacteria, and that's why you can see acid-fast bacilli. Right? There is acid-fast staining showing acid-fast bacilli. And proteins will be elevated, right? Elevated proteins in the CSF. So in the CSF, proteins will be elevated, and these proteins, they get precipitated at the bottom, due to gravity, and those precipitated proteins, they look like cobweb. We call it as cobweb formation. Right? So this is how we identify the bacterial meningitis. Sir, very beautiful picture, very beautiful slide. Right? Acute bacterial and chronic bacterial meningitis. Okay. Next, moving on to the next. So CSF analysis. So CSF analysis is very, very important for meningitis, bacterial meningitis. You know, the important parameters what we see are, sir, cells, glucose, and proteins. Right? Cells, glucose, and proteins. Those are the important parameters what we see. So if you talk about the cells, the normal cells are 0 to 5 per cubic millimeter of CSF. The normal glucose is 20 to 40 per milligram per deciliter of CSF. Normal protein is 15 to 45 milligram per deciliter of CSF. Fine. So with that, sir, high increase in neutrophils you see in acute bacterial meningitis, high decrease in glucose you see in acute bacterial meningitis, and highly elevated protein, right? Highly elevated protein. Okay, this should be like this, right? Highly elevated protein you see in chronic bacterial meningitis. So in CSF analysis, you can identify acute bacterial and chronic bacterial. And 2 points goes in favor of acute bacterial: highly elevated protein and high decrease in glucose. Highly elevated neutrophils and high decrease in glucose goes in favor of acute bacterial meningitis. Highly elevated protein, right? Highly elevated protein seen in chronic bacterial meningitis. So with that, these are the important points for meningitis. Okay, now see the questions. We'll talk about the questions. A child with fever, headache, neck stiffness. You know, neck stiffness means diagnosis is meningitis. CSF examination revealed low glucose, gram-negative pleomorphic organism. You know, gram-negative pleomorphic organism means Haemophilus influenzae B. What is the characteristic of the organism on culture? On culture, how is the organism? You know, Haemophilus on culture shows satellitism in presence of Staph aureus. Sir, very simple, direct, got the answer. Sir, a person manifested with fever, headache, vomiting, and neck rigidity. Again, neck rigidity means diagnosis is meningitis. CSF sample analysis showed slight decrease in glucose and highly elevated proteins forming with a coagulum, like here seen, that is cobweb formation. So this will tell you, right? That the meningitis is chronic bacterial, that is Mycobacterium tuberculosis. That's why the answer is tubercular meningitis. The simple previous, right? The questions which have appeared in the previous exams, easy to answer. So moving on to the next topic. Important topics are bacterial toxin. Right? Next important topic is bacterial toxins. You know, in entire microbiology, virology, mycology, parasitology, and bacteriology, sir, bacteria are the ones which produces toxins. Virus, parasites, they may produce, but very, very rare. Toxins are mainly found in bacteria. in bacteria there are many toxins, but if you talk about the important toxins, the toxins which act by inhibiting protein synthesis, the toxin which act by increasing cyclic AMP, and the toxin which act by inhibiting neurotransmitters. So these are the three types of toxins which are very, very important. First, we talk about the toxins which act by inhibiting protein synthesis. So if protein synthesis has to be inhibited, so you have to inhibit EF2 or you have to inhibit ribosomes. EF2 means elongation factor 2. Any one of these is inhibited, protein synthesis is inhibited. Okay, fine, sir. Now EF2 inhibition and inhibiting the protein synthesis. You see, right, diphtheria toxin of Corynebacterium diphtheria and exotoxin A of Pseudomonas. And inhibiting ribosomes, you see Shiga toxin of Shigella and Virocytotoxin of enterohemorrhagic E. coli. So first two toxins, they inhibit EF2, inhibit protein synthesis. The next two toxins, they inhibit ribosomes, they inhibit protein synthesis. They inhibit proteins. Very simple. So remember, Virocytotoxin. How to remember? I will tell you. Virocytotoxin is also known as Shiga-like toxin. Virocytotoxin is also known as Shiga-like toxin. Shiga toxin, Shiga-like toxin. They act by inhibiting ribosomes, inhibiting protein synthesis. Inhibiting ribosomes, inhibiting protein synthesis. Diphtheria toxin and Pseudomonas exotoxin, they inhibit EF2, inhibit proteins. Easy to remember, two toxins, man, very important. So coming to the increase in cyclic AMP. So increase in cyclic AMP we see with Bacillus anthracis, right? Bacillus anthracis and Vibrio cholerae. Vibrio cholerae. You know, Bacillus anthracis, okay, sorry. The right answer, whatever we told is right. Right, I just want to mention Bacillus anthracis produces a toxin, anthrax toxin. Bacillus anthracis produces a toxin, anthrax toxin, act by increasing cyclic AMP and causes a disease, anthrax. So similarly, Vibrio cholerae produces a toxin, cholera toxin, that also act by increasing cyclic AMP and that causes a disease, anthrax. But what is important is, sir, cholera toxin binds to GM1 ganglioside receptors of the intestine, and binding to GM1 ganglioside receptors, it disrupts the zona occludens tight junction between the cells, and that's how it spreads cell to cell. So remember, 4 act by inhibiting protein synthesis, 2 act by increasing cyclic AMP. One is anthrax toxin of Bacillus anthracis, cholera toxin of Vibrio cholera. And don't forget, cholera toxin, no doubt in that act by increasing cyclic AMP, but before it act by increasing cyclic AMP, it binds to GM1 ganglioside receptor of the intestine, then it disrupts the, what is that? Zona occludens tight junction, and then it spreads cell to cell, and finally it acts by increasing cyclic AMP to cause the disease, cholera. So moving to the last mechanism, important mechanism, inhibiting neurotransmitters. So if you talk about inhibiting neurotransmitters, so inhibiting excitatory neurotransmitter. Inhibiting excitatory neurotransmitters. Inhibiting excitatory neurotransmitters. You know, excitatory neurotransmitter like acetylcholine. Glutamate is also there, but not glutamate. Acetylcholine. And inhibiting the inhibitory neurotransmitters like GABA and glycine. First point you have to remember, excitatory neurotransmitters. Excitatory neurotransmitters, they are responsible for muscle contraction. Inhibitory neurotransmitter, they are responsible for muscle relaxation. This thing you have to keep in your mind. Isko bhulna nahi chahiye. Excitatory neurotransmitter causes muscle contraction. Inhibitory neurotransmitter causes muscle relaxation. So now what is happening? Inhibition of excitatory neurotransmitter. So if excitatory neurotransmitter is inhibited, then there is no muscle contraction because they are responsible for muscle contraction. If there is no muscle contraction, all muscles go to relaxation state because there is no muscle contraction. All muscles go to relaxation state. So no movement. No movement means paralysis, and paralysis due to muscle relaxation is flaccid paralysis, and that is what we see with Clostridium botulinum. So inhibition of inhibitory neurotransmitters like GABA and glycine. I told inhibitory neurotransmitters are responsible for muscle relaxations. When inhibitory neurotransmitters are inhibited, no muscle relaxation. All muscles go into contraction. When all muscles go into contraction, so no movement again. Because movement ke liye contraction, relaxation both has to occur. So no muscle contraction, no muscle relaxation, only contraction, no movement. Paralysis due to muscle contraction, muscle spasm. Right, muscle spasm, sir, spastic paralysis, right, spastic paralysis. And which is the toxin? Sir, toxin, sir, Clostridium botulinum produces botulinum toxin, And Clostridium tetani produces tetanospasmin. Tetanospasmin. Sir, finally, sir, these are the toxins. Right? These are the toxins. I will highlight the toxins here. Right? I will highlight the toxins here. Botulinum toxin and tetanospasmin toxin. They're easy to remember. Clostridium tetani produces tetanospasmin. Spasmin causes muscle spasm. Muscle spasm leads to spastic paralysis. ये pneumonic की need नहीं है ना? Spasmin, tetanospasmin causes muscle spasm. Muscle spasm leads to spastic paralysis. Spastic paralysis means due to muscle spasm because there is no muscle relaxation. Why there is no relaxation? Because inhibitory neurotransmitters are inhibited. Right? These are the toxins which act by inhibiting neurotransmitters. Right? Inhibiting neurotransmitters. So lockjaw, man, lockjaw is also due to paralysis, not spastic paralysis. Yeah, everything is related to spastic paralysis in tetany. Jaw will get locked. Why? Because all the mastication muscles, they go into contraction. So you can't do achieve them. Achieving movement is not happen. Will not happen. Anyways, so these are the important toxins. Important toxins. Toxins act by inhibiting protein synthesis. Four important. And toxin act by increasing cyclic AMP. So 2. There are many more. I have given important, man, which are needed. Important, right? So 2.5 hours class, what else you can discuss? Right? Important, right? Which are appeared in the previous exams. Only that much, right? Otherwise, there are many. Okay, and 2 important toxins which act by inhibiting neurotransmitters. So with that, one important toxin which is important, tetanus toxin. One important toxin which is important. I want to discuss here. What is that? Tetanus toxin. Tetanus toxin. So normally, sir, tetanus toxin in a child, we have to give at 6th week, 10th week, 14th week, and then 18 to 24 months, 5 years, 10 years, and 16 years. 16 years. Sir, 1, 2, 3, 4, 5, 6, 7. Sir, 7 doses. Okay, normally how many doses? Sir, 7 doses we have to give, right? From birth, right, from 6th week till 16 years. After that, every 5 years or every 10 years, you have to repeat the vaccine. Right, you have to repeat the vaccine. Right, coming to the adults. Sir, adults may, sir, we have to take 3 doses. Adults may have to take 3 doses. See, adults may vaccine has to be taken if the vaccine has not taken in the childhood. The vaccine has not taken in the childhood. 3 doses. So that is 0, 1, 6 months. 0, 1, 6 means first dose, second dose after 1 month of first dose, and third dose after 6 months of first dose. After 6 months of first dose, 0, 1, 6 months. So this is what we call it as one series of vaccine. One series of vaccine. One series of vaccine means 3 doses. One series of vaccine means 3 doses. Okay. Now, so first there are 2 things here. Right. What I want to tell you is, first you neglect this. First, this part, don't see this part. Right? Don't see this part. Don't see this part. Which part? Sir, all other wounds. All other wounds means, I will tell you. All other wounds means dirty wounds. Right? Dirty wounds. Severe wounds. Dirty wounds and severe wounds. All other wounds. Sir, first we see clean and minor wounds. Right? First we observe both. If you see together, you will get confused. First you see clean and minor wound. Clean wound, minor wound. Small wound, clean wound. Not dirty means this mud and all, soil and all is not there. Clean wound and minor wound. What to do? So for that you have to take, person has taken the 3 doses of vaccine or not. At least 3 doses. Sir, if person has not taken even 3 doses. If the person has not taken even 3 doses. Right? So anyways we have to take toxin. Anyways we have to take vaccine. Immunoglobulins are not required. Sir, immunoglobulins are not required in clean wound, minor. That is the first point. Immunoglobulins are not required in clean wound. Whether the minimum 3 doses have taken or not taken. Okay, so 3 doses are not taken, otherwise don't know whether taken or not. So got the injury, clean wound, 1 vaccine you have to take. Simple, man. Right, 1 vaccine you have to take. There is no need of immunoglobulin. If more than 3 doses taken, if more than or equal to 3 doses taken, right, and the protective titer is not there. Means the protective titer, antibody titer is 10 milli international units per ml. Protective antibody titer is 10 milli international units per ml. Protective, sir, 3 and more than 3 doses are taken, but protective antibody titer is not there. So what we have to do, is only if last doses, if the last dose more than 10 years ago, then then you have to take. If the last dose given is more than 10 years ago, then you have to take one tetanus toxoid, otherwise no need to take. Then you have to take one tetanus toxoid, otherwise no need to take. Otherwise no need to take. Now if you come to dirty wounds or severe wounds, dirty wounds or severe wounds, so less than 3 doses, so yes, you have to take the toxoid, similar to clean wound, no difference. Clean wound, dirty wound, less than 3 doses, no difference. Sir, anyways, vaccine is not, yeah, but the thing is, immunoglobulin is required. Immunoglobulin is required in dirty wound. Immunoglobulin is required in dirty wound. Okay, one second, I just want to mention that this is not less than, this is more than. Okay, that is not less than, that is more than. That's why I was getting confused. More than means protective titer is there. Protective titer is there. Sir, more than 10, protective titer is there. So 10 years back, if the patient has taken, and from past 10 years not taken, so have to take tetanus toxoid. If dirty wound, sir, 5 years is the cutoff. 5 years is the cutoff. Sir, protective titer is there, immunoglobulin is not required. Protective titer is there, immunoglobulin is not required. Immunoglobulin is not required. Not required. But clean wound, 10 years got over, so take tetanus toxoid, and dirty wound, 5 years got over, to take tetanus toxoid. Take tetanus. Sir, immunoglobulin went. Sir, whatever happens, see, you have to take tetanus in less than 3 doses. Anyways, you have to take tetanus toxoid. More than 2 doses, there is a cutoff time period. For clean wound, it is 10 years. For dirty wound, it is 5 years. Immunoglobulin to be taken only if vaccine is not taken earlier 3 doses and if the wound is dirty and clean. Simple. Right? Once again, I will summarize very simple, in a simple way. Right? Sir, 3 doses or less than 3 doses. Less than 3 doses are not taken earlier. Right? Whether clean wound or dirty wound, you have to take 1 dose of vaccine. But in dirty wound, you have to go for immunoglobulins. If more than 3 doses are taken, last 10 years cut off for clean wound and 5 years cut off for dirty wound. You have to take the vaccine, no need of immunoglobulin. Sir, with that, we are moving on to the questions. A 20-year female working in a school in a rural area developed rice watery diarrhea. Sir, rice watery diarrhea means cholera. Rice watery diarrhea means cholera. The organism responsible for this condition act via which receptor? So you know the answer, GM1 ganglioside receptor. We have discussed. GM1 ganglioside receptor. Okay. Mechanism of action of Clostridium botulinum toxin. Mechanism of action of Clostridium botulinum toxin. Sir, Clostridium botulinum, you know, it acts by inhibition of excitatory neurotransmitter, that is acetylcholine. Inhibition of excitatory neurotransmitter, that is acetylcholine. No muscle contraction, flaccid paralysis. Sir, moving to the next question. A person met with a RTA 4 hours back, presented with clean wound without laceration. Sir, wound is clean wound. History of tetanus vaccine taken 10 years back. Clean wound, but 10 years back vaccine is taken. From past 10 years vaccine is not taken. Sir, 1 dose of TT. And 1 dose of TT. Right. Simple. 1 dose of TT. Clean wound 10 years back has taken. But if the person would have taken tetanus toxoid past 5 years or 6 years back, right? So nothing to be done. No vaccine, no immunoglobulins. Because 10 years back patient has taken, so 1 dose you have to give. If it is a dirty wound 5 years back, if the patient has taken, then 1 dose of vaccine. 1 dose of vaccine. If person is not taken previously proper vaccines, right? So clean wound, just again 1 vaccine, dirty wound 1 vaccine plus 1 immunoglobulin. Simple. Hope you have understood now. So moving to the next. Bacterial vector transmitted diseases. Bacterial vector transmitted diseases. Sir, bacterial diseases transmitted by vectors. So here I want to divide first 3 and the next 2. Sir, why to divide first 3 and the next 2? Sir, first 3 are transmitted by louse. The next 2 are transmitted by rat flea. Sir, Rickettsia provozaki. causing epidemic typhus, Bartonella quintana causing trench fever, and Borrelia burgdorferi causing Lyme's disease. These are the three important bacterial diseases transmitted by louse. And you know, Lyme's disease manifests with target rash. Lyme's disease manifests with target rash. Target rash. Sir, Yersinia pestis causes plague transmitted by rat flea, and Rickettsia typhi endemic typhus transmitted by rat flea. And the students have attended my classes, you know how to remember without mnemonic, right? How to remember without mnemonic, right? So now Rickettsia causes Rocky Mountain spotted fever. Rickettsia conuri causes Mediterranean spotted fever. You know it is transmitted by Ixodes tick. Ixodes tick means hard tick. Rickettsia acari causes rickettsial pox, and Orientia susugumushi causes scrub typhus, and it is transmitted by mite. And you know scrub typhus is manifest with black eschar. Scrub typhus manifest with black eschar. So these are the important bacterial diseases transmitted by vector. And the four important vectors are louse and flea, tick and mite. First remember the vectors: louse and flea, tick and mite. Sir, bacteria are transmitted by only four vectors. Bacteria are transmitted by only four vectors: louse and flea, tick and mite. Easy to remember: louse and flea, tick and mite. Okay, louse के लिए 3, flea के लिए 2, tick के लिए 2, sir mite के लिए 2 bacteria. Sir, louse के लिए we have 3, but remaining 3 we have 2 bacteria. You have to remember. Sir, if you remember like this, you can answer the questions in the exam, right? The way you want, you can remember. I've just divided based on the vector, and I told you how to remember the vector: 2 plus 2, louse and flea, tick and mite. Louse and flea, tick and mite. Remember 3 for louse, 2 for flea, and 2 for louse, and 2 for tick, and 2 for mite. If you remember like this, easy to remember. All right, and the students who attended my class, you know how to remember. But for other students, I'm telling remember like this. So with that, now if you see the questions on vector. So there were infectious outbreak in the village. Infected patients presented with multiple buboes in the inguinal area. Sir, buboes are there in the inguinal area, so bubonic plague. So no other manifestation, only buboes. Buboes means enlarged lymph nodes. So bubonic plague, which is the vector responsible for this condition. You know, bubonic plague is transmitted by Yersinia pestis, right? It is caused by Yersinia pestis. And you know, Yersinia pestis is transmitted by rat flea. It is transmitted by rat flea. And rat flea is known as Xenopsilla chiopis. Rat flea is known as Xenopsilla chiopis. Sir, very simple question. Sir, moving to the next. A 30-year-old military Jawan complains of fever, vomiting and myalgia. Sir, fever, vomiting and myalgia in a military Jawan. Similar complaints are found in others. All were suffering from infestation of lice. Lice. Right, lice. So now lice, if you see lice here. So lice means plural form of louse. Right, epidemic typhus, trench fever and Lyme's disease. Rickettsia prowazekii, Bartonella quintana, Borrelia burgdorferi. So 3 possibilities. And if you see in the question, if you see in the options, we have Rickettsia prowazekii, which causes epidemic typhus. Rickettsia prowazekii, which causes epidemic typhus. Epidemic typhus. Lice. Simple, man. You got the answer. Moving on to the next topic. Sir, moving on to the next topic. Next topic is, sir, pneumonia. Next topic is pneumonia. You know, pneumonia means lung infection. When there is lung infection, there is breathing difficulty. There is breathing difficulty, right? And if consolidation is there, that is typical pneumonia. Typical pneumonia. If consolidation is not there, you know, that is atypical pneumonia. If consolidation is not there, that is atypical pneumonia. And you know, typical pneumonia is caused only by bacteria. Typical pneumonia is caused only by bacteria. The most common cause of typical pneumonia is pneumococcus. Pneumococcus. The most common cause of nosocomial pneumonia is Staphylococcus aureus. The most common cause of pneumonia in cystic fibrosis patient is Pseudomonas. Pseudomonas. And the most common cause of, right, pneumonia in ventilator associated patients. Ventilator associated pneumonia is Acinetobacter. Acinetobacter. Right, I can say etc, 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 etc. There are many more. So this is the most common cause of pneumonia. Pneumococcus is the most common cause of pneumonia. Most common cause of pneumonia. Right, Staphylococcus is the most common cause of nosocomial pneumonia. Nosocomial pneumonia. Sir, Pseudomonas is the most common cause of pneumonia in cystic fibrosis patient. Cystic fibrosis. Sir, Acinetobacter is the most common cause of ventilator associated pneumonia. ventilator associated pneumonia, right? So atypical pneumonia is caused by bacteria, right? Bacteria like chlamydia, mycoplasma, sir, legionella. These are the three important bacteria which causes atypical pneumonia, right? And you know the most common is mycoplasma. Here the most common is pneumococcus. And no viruses, sir, coronavirus, influenza virus, sir, adenovirus, they cause pneumonia. And you know most common is coronavirus, viral pneumonia. Sir, if you talk about the fungi, sir, nine systemic fungi causes pneumonia. Right? 9 systemic fungi causes pneumonia. The most common is aspergillus. And if you talk about parasites, sir, one parasite, sir, Paragonus westermani causes pneumonia. So with that, these are the important organisms that causes pneumonia. Typical and atypical. Typical caused only by bacteria, atypical by bacteria, virus, fungi and parasites. And typical may consolidation will be there. So this I want to highlight. Right? Dyspnea is there, pneumonia, consolidation is there, typical pneumonia, no consolidation, atypical pneumonia. So typical pneumonia is caused only by bacteria, whereas atypical by bacteria, viruses, fungi and parasites have given the important organisms. Right? This is the topic pneumonia. So with that, now if you see the questions which are before that, so diagnostic algorithm of pulmonary TB. So how will you diagnose Mycobacterium tuberculosis? You know, we can do microscope, you can see acid fast bacteria, you can do the culture on LJ media, you can do molecular method, that is PCR, that is CBNAT, you can do chest x-ray, radiological, immunological, you can do IGRA, interferon gamma releases, all these things are there. But there is a guidelines which says how to proceed. Sir, guidelines says first you have to do smear examination. Nothing but ZN staining. That is acid fast staining. Right? Nothing but ZN staining, that is acid fast staining. Nothing but microscopy. Along with that, you have to do chest x-ray. Sir, chest x-ray, whether findings positive or negative, it doesn't matter to the algorithm. That's why no need to worry. Yes, you have to do chest x-ray, but we are least bothered about chest x-ray. First to do is microscopy, acid fast staining, smear examination. Right? Smear examination. And then next what to do is CBNAT. Okay. So once you do smear examination, if it is positive, then you have to confirm by CBNAT. If it is positive, you have to confirm by CBNAT. Negative, then also you have to confirm by CBNAT. So again, smear examination positive or negative, you have to confirm by CBNAT. Chest x-ray positive or negative, you have to confirm by CBNAT. Sir, guideline says first do smear examination and chest x-ray. Whether they are positive or negative, I have to confirm by CBNAT. Positive also you have to confirm by CBNAT. Negative also you have to confirm by CBNAT. If they are positive, anyway CBNAT will be positive. If they are negative, they may miss. CBNAT will finally tell positive. So final result is completely dependent on CBNAT. After that, if you have any doubts, you can do the immunological test, IGRA, interferon gamma releases. You can do the Monto test, tuberculin test. You can do the culture, whatever you want to do, you do. But guideline says first to perform is microscopy. And radiology. Second to perform is CBNAT. So this is the algorithm you have to remember for TB. So we have many tests to diagnose, but this is algorithm. This is what it says. So with that, now if you move on, a patient presented with fever, cough, respiratory distress. Sir, respiratory distress, diagnosis pneumonia. On auscultation, crepitations was present and X-ray showed consolidation. Consolidation is there, typical pneumonia. Right? CD4 count was 55. Right? What is the most likely causative agent? Sir, pneumonia, typical pneumonia. And you know, typical pneumonia is caused by bacteria. And you know, the most common bacteria causes typical pneumonia is pneumococcus. And a pneumococcus, we have discussed. And one more name of pneumococcus is Streptococcus pneumoniae. And that's why the answer is Streptococcus pneumoniae. That's why the answer is Streptococcus pneumoniae, because it is pneumonia and it is typical pneumonia, and the most common cause of typical pneumonia is pneumococcus. So CD4 count 55, don't get confused. CD4 count 55, right, goes in favor of Pneumocystis cerevisiae, but consolidation goes in favor of Streptococcus pneumoniae. Right, consolidation means typical pneumonia. Typical, sir, what you need to know is Pneumocystis cerevisiae is a fungi. Pneumocystis cerevisiae is a fungi, and you know fungi cause atypical pneumonia, and there is no consolidation in fungi. Fungi cause atypical pneumonia, and there is no consolidation in fungi. Right? If no consolidation in fungi, if the question mentions no consolidation, and CD4 count is 55, the answer will become Pneumocystis cerevisiae. Answer will become no Pneumocystis cerevisiae if question mentions no consolidation. Right, then atypical, because I told you here, you know, typical pneumonia is caused by bacteria, only bacteria, not fungi. Right, typical pneumonia is caused only by bacteria, not fungi. Diagnosis here is typical pneumonia, but consolidation is there, and that's why it is Streptococcus pneumonia. No consolidation, then the answer is Pneumocystis, because CD4 count is 55. You should not get confused here. Right, so with that, next question: a patient with fever, cough, and chronic cough, sputum, this is important, sputum negative, chest x-ray positive, sputum negative, chest x-ray positive. What is the next step? I told you, whether you do sputum examination or chest examination, whatever it is, next what to do is CBNAT, and CBNAT is nothing but automated PCR. CBNAT is nothing but automated real-time RT-PCR. First you have to understand that it is nothing but PCR. RT-PCR, nothing but real-time RT-PCR. The only thing is it is automated. I will highlight this. CBNAT is nothing but automated real-time RT-PCR. So with that, these are the important questions from respiratory system. So moving on to the bacterial gastroenteritis. Right. There are many bacteria that causes gastroenteritis, but there are only 3 bacteria which produces preformed toxins. Preformed toxins, toxins are already formed. Because toxins are already formed, incubation period is short. Short means how much, sir? Less than 6 hours. Incubation period is short, less than 6 hours. And the 3 bacteria which produces preformed toxins are, one is Staphylococcus aureus, second is Bacillus cereus, third is Clostridium botulinum. So Staphylococcus aureus produces a toxin enterotoxin, which is found in milk and milk products. Bacillus cereus produces emetic toxin, which is found in fried rice, and botulinum toxin produces C2 botulinum toxin, which is found in canned food. These are the 3 bacterial toxins which are preformed. Because their preformed incubation period is short, less than 6 hours, all other bacterial toxins causing gastroenteritis, they are post-formed. So remember these 3 bacteria, their toxins and the food. Easy to remember: Staph aureus, enterotoxin, milk and milk products; Bacillus cereus, emetic toxin, fried rice; Clostridium botulinum, C2 botulinum toxin, canned food, present in canned, preserved food, ready to eat, ready to cook food. Right. So based on this bacterial gastroenteritis, if you see the questions which have appeared in the previous exams, so 20 people attended party late night. Out of which 2 people developed severe bouts of vomiting early morning. Sir, party late night, early morning symptoms means they are telling incubation period is short. Late night party, that is important, and a late night party and early morning symptoms, incubation period is short. So incubation period is short for Staph aureus, enterotoxin, and Bacillus cereus, emetic toxin. These 2 though ruled out, because I told you 3. Both of them had history of consumption of pastry in the party. Sir, I want to highlight the food source. Sir, incubation period is short and the food source is pastry. Right? Pastry is nothing but milk product. You know, pastry is nothing but milk product. And if you see the milk product, just now explained, sir, milk product, Staphylococcus enterotoxin. That's why answer is Staphylococcus enterotoxin. Don't get confused here saying vomiting. Vomiting means students say, sir, Bacillus cereus, emetic toxin, fried rice. No, don't say that. If the question mentioned instead of pastry, if the question mentioned fried rice, 2 people had history of eating fried rice, then the answer will become Bacillus cereus, emetic toxin. Right? Here the answer is Staphylococcus aureus, enterotoxin. Right? Moving on to the next question. Sir, important bacterial zoonotic diseases. Next topics are important bacterial zoonotic disease. Zoonotic means acquired from animals. So 3 important diseases we discuss here. Three important diseases. One is brucellosis, which is a gram-negative cocoa bacilli. Which is a gram-negative cocoa bacilli. So second is leptospirosis. You know, which is a spirochete. Gram-negative spiral bacilli. Sir, one more what we discuss is glanders disease. Which is caused by Burkholderia pseudomallei. You know, which is a gram-negative bacilli. So these are the three important diseases which are important bacterial zoonotic diseases. Many more, these are important. Zoonotic means acquired from animal. So acquired from animal means first thing you have to say which animal. So brucellosis is acquired from cattle. The leptospira is acquired from the rat. And glanders disease acquired from the horse. That is important. Okay, now brucellosis acquired from cattle. Manifest with hepatosplenomegaly. Sir, myalgia and arthralgia. I want to highlight these features. Which features? Sir, myalgia and arthralgia. Very important. Body pain, severe body pain. In leptospirosis, hepatosplenomegaly, sir, renal failure, cough, muscle tenderness, and conjunctival suffusion. Very, very important. I want to highlight these features. Right? That's how you diagnose clinically. And finally, sir, there is a special test for the diagnosis of brucellosis, that is standard agglutination test. Right? Standard agglutination, and for leptospirosis or microscopic agglutination test. Right? Standard agglutination test for brucellosis, microscopic agglutination test for leptospirosis. So this is about brucellosis, leptospirosis. Moving on to the glanders disease. Glanders disease is a zoonotic disease acquired from horses caused by Burkholderia mallee. What does it cause? Pneumonia. And how will you identify? Sir, special test for pseudomalley is oxidase positive or negative. Variable. Maybe positive, maybe negative. But motility, negative. Okay, once again, I'm not able to edit these things. Okay. Motility negative. Sir, oxidase positive or negative? Sir, usually we consider negative, but maybe positive also. Positive or negative, motility negative. That's how you identify it as Burkholderia mallee. The three important bacterial zoonotic diseases are very important in front of you. Very, very important. Very, very important. Everything is important because all are right. Previous PYTs, previous year topics, all are previous. But these three diseases are very, very important. Brucellosis, leptospirosis, glanders disease, multiple times repeated. So now coming to the question, a young boy presented with fever, sore throat, malaise, abdominal pain. Sir, conjunctival suffusion. Sir, I want to highlight now here conjunctival suffusion. I want to highlight cough, muscle tenderness. Sir, clear cut picture they have told. There is nothing, no difficulty here. Leptospira, very simple direct question. Sir, moving on to the next, sir. A child who works in the sewage came with the complaints of fever and again conjunctival suffusion. When leptospirosis, very simple. Leptospirosis. Now they are asking, sir, what is the investigation of choice? And you know, special test is right. Special test is microscopic agglutination test for leptospirosis. Right. Just now we have discussed and we have written. Brucellosis standard agglutination test, leptospirosis microscopic agglutination test. HSM means hepatosplenomegaly. Right. So with that, moving on to the next topic. So next topic is urethritis. Urethritis. You know, there are two types of urethritis: gonococcal and non-gonococcal. And gonococcal urethritis and non-gonococcal urethritis. Gonococcal caused by gonococcus, non-gonococcal not caused by gonococcus. And urethritis means there should be urethral discharge. That is discharge coming out from the urethra. You just have to see the discharge here. The discharge is thick. Pus-like or thin, water-like. If the discharge is thick pus-like, like you see in the first image, this image, thick pus-like discharge, so gonococcal. And if you see here, thin water-like discharge, so non-gonococcal. Very simple. Sir, if I see urethral discharge, urethritis, thick pus-like, gonococcal urethritis, thin water-like, non-gonococcal urethritis. Sir, gonococcal urethritis caused by gonococcus. Right, gonococcus is Neisseria gonorrhoeae, like meningococcus, Neisseria meningitis. Right, so they are gram-negative cocci. Arranged in pairs. arranged in pairs, and intracellular, arranged in pairs and intracellular, present within the pus cells, present within the pus cells. These are pus cells containing gram-negative cocci in pairs inside, and these big pink color structures are nuclei of neutrophils. These dark color dots, these dots, right, dark color dots, those are the, yeah, the gram-negative cocci in pairs. One second. Yeah, luckily came back. Okay, we had, sir, gram-negative pairs, intracellular, meningococcus, gonococcus, difficult to differentiate on gram stain. Though theoretically we can say meningococcus is lens-shaped, capsulated, gonococcus is kidney-shaped, non-capsulated. But practically, when you see the images, difficult to say lens-shaped, difficult to see lens-shaped, capsulated, kidney-shaped. That was difficult. Sir, within the neutrophils, okay, within the neutrophils, right, within the neutrophils, if you see pink color dot 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 dot, those are either meningococcus or gonococcus. Sir, how will you identify meningococcus or gonococcus? If the disease is meningitis, meningococcus. If the disease is urethritis, gonococcus. Simple. Because meningococcus causes meningitis, gonococcus causes gonococcus causes urethritis. So now, thick pus-like discharge, thick pus-like discharge, thick pus-like discharge, and gram-negative cocci arranged in pairs which are intracellular, gonococcus. Drug of choice is ceftriaxone. Drug of choice is ceftriaxone. So thin water-like discharge, right? Non-gonococcal. Non-gonococcal means, so it can be chlamydia, mycoplasma, ureaplasma, bacteria, or herpes simplex virus 2 virus, Candida albicans fungi, and Trichomonas vaginalis parasite. These are the ones which causes non-gonococcal urethritis. Among the non-gonococcal urethritis, the most common is chlamydia. Among the non-gonococcal urethritis, the most common is chlamydia. So with that disease, urethritis. With that, now let's see the questions, previous year questions on urethritis. A patient with history of unprotected intercourse complains of burning picture, a urethral discharge. So urethral discharge is their diagnosis is urethritis. Diagnosis urethritis. Urethral discharge as shown in the picture. As shown in the picture, if you see the picture, right? If you see the picture, you can see thick pus-like discharge. Thick pus-like discharge. So thick pus-like discharge, you know, this is gonococcus. This is gonococcus. Gonococcal urethritis. Sir, gonococcal urethritis caused by Neisseria gonorrhea. Very simple, man. Straightforward question. See how easy it is to identify. So moving on to the next question. A patient with multiple sexual partners manifested with urethral discharge. Sir, urethral discharge means urethritis. Urethral discharge means urethritis. Gram stain showed the following organism. Sir, gram stain showed the following organism. What is the following organism? Sir, gram-negative cocci arranged in pairs intracellular. Arranged in pairs intracellular. Therefore, obviously it is gonococcus. Obviously it is gonococcus. So, you know, it is gonococcal urethritis. See, the only way of asking gone different. That's it. Sir, in first they say urethral discharge and they gave the clinical picture, thick pus-like discharge, so gonococcal urethritis. So second question, right, urethral discharge with the organism picture they have given, gram-negative cocci in pairs intracellular, gonococcal urethritis. And what they have asked here is treatment, and you know, drug of choice for gonococcal urethritis is ceftriaxone. You got the answer. So move to the next question. Genital ulcerative diseases. You know, genital ulcers are caused by 4 bacteria, right? 4 bacteria: Klebsiella granulomatis, Haemophilus ducreyi, Treponema pallidum, and Sir, Chlamydia trachomatis. And the disease caused by Klebsiella granulomatis is granuloma inguinale, Haemophilus ducreyi is chancroid, Treponema pallidum causes syphilis, and Chlamydia trachomatis causes LGV, lymphogranuloma venereum. How is the ulcer? That is important. Sir, how is the ulcer? That's the question now. Okay, if you ask me, how is the ulcer? If you ask me, how is the ulcer? Sir, ulcer is red and beefy. Red and beefy. Painless ulcer with pseudobuboes. right? Red, beefy, painless ulcer with pseudobubose, right? Red, painless ulcer with pseudobubose. Okay, red, beefy ulcer, painless ulcer with pseudobubose. In Haemophilus ducreyi chancroid, soft, painful ulcer with painful bubose, painful ulcer, painful bubose. Treponema pallidum syphilis, hard, painless ulcer and painless bubose. Right? Chlamydia trachomatis, transparent, painless ulcer with painful bubose. Right? So this is how you to identify. So in simple words, first I want to highlight. Pseudobubose is there. First I want to highlight pseudobubose is there. Right, Klebsiella granulomatis. Remember this. Pseudobubose we found only in Klebsiella granulomatis. Then painful ulcer, painful bubose. Okay, once again I want to highlight painful ulcer and painful bubose. Painful ulcer, both are painful. Ulcer is also painful, bubose is also painful. Haemophilus. Painless ulcer, painless bubose. Both are painless. Both are painless. Both are painless. Ulcer is also painless. Bubose are also treponema pallidum syphilis. So pseudobubose is there. Klebsiella. Both are painful. Haemophilus. Both are painless. Both means ulcer and bubose. Both are painless. Treponema pallidum. And one is painless. One is painful. Painless ulcer. Painful bubose. So chlamydia. This is how you have to remember. Right? How to remember? That is also I have told. Pseudobubose. Pseudobubose. Right? Pseudobubose. Klebsiella, both are painful. Haemophilus, both are painless. Treponema pallidum, and painless ulcer, painful bubose, or chlamydia trachomatis. Genital ulcer. Simple, easy to remember. With that, now if you see the questions appeared in the previous exams, a patient with painless genital ulcer, non-tender, sir, painless ulcer, painless lymph node, syphilis. Simple question, man. Painless, both are painless. Syphilis, treponema pallidum. Now moving on to the next question. So next topic, previous year topic is osteomyelitis, bone infection. So if you talk about osteomyelitis, so osteomyelitis in patient without sickle cell anemia, osteomyelitis in patient suffering from sickle cell anemia, the most common organism differs. Without sickle cell anemia, the most common is Staphylococcus aureus, right? The most common is Staphylococcus aureus, and in sickle cell anemia, the most common is Salmonella. That's it. With that, now if you see the question, a patient with sickle cell disease presented with pain and swelling of the knee joint, lytic lesions on the sclerotic borders. So all these things they say, right? All these things, pain and swelling of the knee joint. Right. So osteomyelitis in sickle cell anemia patients are Salmonella. Picture they have given gram-negative bacilli. Salmonella is a gram-negative bacilli. Right, gram-negative bacilli. Anyways, so these are the questions from bacteriology. So completed questions from general microbiology and bacteriology. So moving on to the virology. So first we'll talk about viral inclusion bodies. Again, there are many. Again, to be more specific, important viral inclusion bodies. So three important viral inclusion bodies. One is rabies. Second is yellow fever virus, and third is cytomegalovirus. So rabies may you get Negri bodies, and yellow fever may you get Tories bodies, and cytomegalovirus may you get owl eye appearance. Right? Okay, now. Sir, if you ask me, sir, where is the Negri bodies? If you ask me where is the Negri bodies, you know, Negri bodies are found in the brain. Hippocampus and cerebellum. So what is this? This is brain tissue. What is this brain tissue? What is this? So this is axon. What is this? So this is cell body. Right? That is axon. This is cell body. So total this is neuron. This is the nucleus. So this is the neuron. This is what? Neuron, axon, cell body, and nucleus. This is a brain tissue because Negri bodies are found in the brain, hippocampus and cerebellum. Sir, brain biopsy is taken, neuron is seen. Within the neuron, in the cytoplasm, what you see here, these dark color round maroon structures, and these are Negri bodies. These dark color round maroon structures, these are Negri bodies. If I remove, then you will see here. So these are Negri bodies. Okay. Now Tori's bodies. So Tori's bodies are found in the liver. Tori's bodies, because yellow fever affects the liver. Yellow fever causes viral hemorrhagic fever with hepatitis. Viral hemorrhagic fever with hepatitis. So this is liver tissue, and in the liver tissue, what you see, the green color marked one, the green color marked pink color bodies, right? Pink color bodies, right? If you observe here, the green color in the arrow mark. See, actually, I will highlight here. Actually, this one, sir, this one, this one, this one, this one. So those are Negri bodies. Sorry, those are Tori's bodies. The small rounds in which you see pink color, sir, pink color. Those are Negri bodies. Again, here also dark pink color, here also pink color. Green color arrow mark showing pink color bodies. Pink color eosinophilic bodies. Eosinophilic bodies are Tori's bodies seen in the liver tissue. Sir, cytomegalovirus, right? Owl eye appearance. Owl eye appearance, right? Sir, cytomegalovirus, right, causes, right, many infections like meningitis, pneumonia. So any tissue you can take if it is causing pneumonia, right? If it is common pneumonia, sir, most common site is lung, right? So most common site is lung tissue. So you can see, what is that? Owl eye appearance. These are the important inclusion bodies, sir, looking like owl eyes, right? You know, these are the inclusion bodies, owl eyes. So I've shown you the Negri bodies and yellow fever bodies, Tori's bodies in yellow fever. These are the important inclusion bodies, right? So with that, now if you see the question, sir, owl eye inclusion bodies are seen in very simple, straightforward question, cytomegalovirus, right? Cytomegalovirus, sir, you are great, sir. Thank you, man. Viral, okay, cytomegalovirus, sir. With that, viral inclusion topic is over. So moving to the next topic, sir, viral vaccines. Sir, viral vaccines are very, very important. So two types of vaccines are important. One is live vaccine, and one more is subunit vaccines, which are also known as recombinant vaccines. Two types of vaccines are important, live and subunit. Or subunit are nothing but recombinant. The live vaccines. First point you have to remember, so live vaccines are contraindicated in immunocompromised and pregnancy, right? That is the first point you have to remember. Live vaccines are contraindicated in immunocompromised and pregnancy. So now important live vaccines are, sir, if you talk about the important live vaccines, the one which are taken inhalationally, orally and subcutaneous. The live vaccines are taken by three routes: inhalation, oral, subcutaneous. That is also important. That is also what they ask. What is the route? Sir, inhalation route, easy to remember, I for eye, influenza. Oral route, OPV and rota. OPV drops, rota drops. Sir, subcutaneous route, sir, inhalationally have given 1, orally have given 2, subcutaneously have given, right, 8 vaccines. 8. Which are the 8? Smallpox, chickenpox, subcutaneous route, live vaccines. 3 flaviviruses, JE, dengue and yellow fever, right, subcutaneous route. Then MMR, mumps, measles and rubella, subcutaneous. These are the 8 vaccines given via subcutaneous route are live vaccines. So inhalationally influenza, orally OPV and rota, subcutaneously smallpox, chickenpox, JE, dengue, yellow fever, flaviviruses, mumps, measles and rubella. These are the 8 vaccines which are live vaccines. 8 plus 2 plus 1, totally 11 vaccines are live vaccines, right? Totally 11 vaccines are live vaccines. Route of administration is important and they are contraindicated. That is important. The strains used in the live vaccines are important, but not all the vaccines strains are important. So these 6 vaccines strains are important. What is the strain? So if you talk about the strain, Japanese encephalitis virus SA1414-2, dengue virus CYD TDV strain, yellow fever virus 17D strain, mumps virus Gerillin strain, measles virus Edmondson strain, and rubella virus RA27-3 strain. Right, these are the strains. So these are about the live vaccines. 3 things are important in live vaccine, so that they are contraindicated in immunocompromised and pregnancy, route of administration, and the strains of the vaccines. All the live vaccines, sir, only these are the live vaccines in virology. These are the live vaccines in virology, right? And these are the questions asked. So moving to the subunit vaccines. Sir, which is the subunit? Subunit or recombinant vaccine means only one subunit is present in the vaccine. Which is the subunit which is present? right? Sir, hepatitis B virus, HBs antigen subunit is present. HPV, human papilloma virus, L1 antigen subunit is present in the vaccine. Coronavirus, S antigen means spike receptor antigen subunit is present. So again, what is important here is which is the subunit is present. At subunit vaccine means whole virus will not be there inside the vaccine. One unit, one antigen will be there. Which antigen is there in the vaccine? That is what they ask. So this is what they ask. This is about the vaccines of the viruses. Live vaccines. Only these viruses have live vaccine. Only these viruses have subunit or recombinant vaccines. The remaining viruses they have, right? Remaining viruses they have either killed vaccine or no vaccine. Okay, Beijing strain, Nakayama strain for JE virus, that is for killed vaccine. Killed vaccine, JE virus is having live vaccine and also killed vaccine. JE virus ka live vaccine strain is SA1442. Killed vaccine ka strain is Beijing and Nakayama strain. That is not important. Important one we have discussed. Okay, so with that, now moving on to the questions on the viral vaccines. Sir, a 3-year-old child presented with recurrent respiratory tract infection means the child is immunocompromised. Sir, an immunocompromised child will get a recurrent respiratory tract infection. Should not be given what type of vaccines? You know, immunocompromised conditions, live vaccines are contraindicated. Live vaccines are contraindicated. Now they are simply asking which is the live vaccine among the following. Sir, I have given all the live vaccines in virology. Sir, MMR is a live vaccine. MMR is a live vaccine. Right? It is a killed vaccine. IPV is a killed vaccine. TT, tetanus toxoid is a toxoid. Toxoid. Right? Tetanus toxoid is a toxoid. So DPT, DNT are toxoids. DNT are toxoids. Again, diphtheria, toxoid, tetanus. Pertussis is a killed vaccine. Right? Easy to identify. If they are not under killed, if they are not under live or subunit, so killed vaccines. And toxoid, so we have only two toxoid, no, diphtheria and tetanus toxoid, two toxoid. So therefore, live vaccine is not given. The answer is A. MMR is a live vaccine. Mumps, measles, and rubella. A person traveled from Egypt, developed an infection. Turi's bodies were demonstrated in the specimen. So you know the person is suffering from yellow fever virus infection. Which strain of the organism is used in preparing the vaccine? You know, yellow fever virus ka strain they have asked. You know the strain is 17D strain. Very simple, man. Straightforward, easy questions. 17D strain. So there was an outbreak of encephalitis, right? Bin, not bin, man. It is in a community in the northern Indian states. So northern India, there is an outbreak of encephalitis in the northern India. Sir, encephalitis in northern India, Japanese encephalitis virus, because Japanese encephalitis virus, encephalitis is seen mainly in northern India, southern India, it is very, very rare. What is the type and route of administration of the vaccine? You know, JE virus, just now I told live vaccine given via subcutaneous route. We have written, and we have written, right? I've showed here, see here, right? JE virus, live vaccine, and subcutaneous route, subcutaneous route. And see yellow fever virus 17D strain, right? All the questions have been asked, answered, right? Moving on to the next questions. Our big question is based on hepatitis B virus, right? We have started, don't forget, we have started with general microbiology is over, bacteriology is over, we have started with virology. We are with virology. Sir, hepatitis B virus, lab diagnosis and treatment. Hepatitis B virus, lab diagnosis and treatment. You know, hepatitis B virus is having three antigens: HBs antigen, HBe antigen, HBc antigen, and our body produces antibodies against all the three antigens. And you know, HBc antigen, HBc antigen, HBc antigen is not detectable. It is not detectable. All other things are detectable. Only HBc antigen is not detectable. And with that, now you see, now if you see in this graph, right, HBsAg is detectable, HBeAg is detectable. And also if you see, anti-HBc is detectable, anti-HBe is detectable, and anti-HBs is also detectable. Two antigens, three antibodies. One antigen is not detectable, that is HBc antigen is not detectable. So two antigens and three antibodies. But what we have to focus here is, sir, I will divide this, see here. What you have to focus here is, right, division is very important. Division here is very important. Okay, so this is, if you see, this is the phase of infection. Okay, one second, I will make it clear here. This is the phase of infection. The phase of early recovery. Now, early recovery phase is also known as window period. Early recovery phase is also known as window period, and this is, I will call it as complete recovery. This is complete recovery. Complete recovery. Right? Infection period, early recovery period, complete recovery period. That is the first thing. Infection period, early recovery period, complete recovery period. And antigens are found only at the time of infection. So HBsAg and HBeAg both are found at the time of infection. They are not there in early recovery and late recovery. Antigens won't be there. And remember, HBsAg is a marker of infection. HBsAg is a marker of infection. So HBsAg is there, infection is there. HBsAg is not there, infection is not there. And HBeAg is a marker of infectivity. HBeAg is a marker of infectivity. HBeAg is there, patient is having high infectivity. Not there, patient is having low infectivity. This is what you have to remember first. Antigens are found only at the time of infection. They won't be there at the time of recovery. And there are only two antigens which are detectable because third antigen HBcAg is not detectable. And the two antigens are detectable, and those both of them are detectable at the time of infection, not there at the time of recovery. HBsAg is the marker of infection. HBsAg is there, infection is there, not there, infection is not there. HBeAg is a marker of infectivity. HBeAg is there, high infectivity, not there, low infectivity. Three antigens ke bare mein we have done. Now coming to the antibodies. Antibodies. Right? If we talk about antibodies, anti-HBe is the first that appear at the time of infection. Anti-HB is the first that appear at the time of anti-HBc. Anti-HBc appeared at the time of infection. Anti-HBe, though it starts at the end of the infection, but it mainly found in the early recovery. Whereas anti-HBs, see, it is found in the complete recovery. So very simple, three antibodies in three different phases. Remember, anti-HBc, infection; anti-HBe, early recovery, window period; anti-HBs, complete recovery. Right? Three antigens, three antibodies. Hope you have understood. Right? First of all, once again, I am telling you, antigens are found only at the time of antigens are there, infection is there. HBeAg is there, decides high infectivity. Along with that, we detect one antibody, anti-HBc. Remember, at the time of infection, we detect only one antibody, anti-HBc. Anti-HBc will decide acute or chronic infection. Anti-HBc will decide acute or chronic infection. IgM of anti-HBc acute, IgG of anti-HBc chronic. And remember, anti-HB come at the time of early recovery, and anti-HBs come at the time of complete recovery. Simple. Through two antigens, three antibodies. When they will come, in which phase? Infection, recovery, and complete phase. Early recovery and complete recovery. Remember, early recovery is known as window period. Right? Window period. So when you say early recovery, sir, early recovery we say, right? Early recovery we say when you get, right? What is this? Anti-HBc. And what is this? Anti-HBe. So if you see two antibodies, anti-HBc and anti-HBe, so early recovery. Sir, complete recovery. You see anti-HBc, anti-HBs, and this is anti-HBe. All the three antibodies. Because anti-HBs will appear. So three antibodies. Right. So what we see in every phase, that is important. Infection may we see two antigen and one antibody. Two antigen, HBsAg and HBeAg, and anti-HBc. Two antigens, one antibody in infection. In early recovery, two antibodies. In late recovery, in complete recovery, three antibodies. This is what is important. Right? Hope you have understood. Once again, if you watch the video, you will understand. And treatment, drug of choice for hepatitis B is tenofovir, and it has to be taken more than 1 year. Tenofovir more than 1 year. Pegylated interferon alpha may be added, but because it is hepatotoxic, it is better to avoid. It is better to avoid pegylated interferon alpha because it is hepatotoxic. So this is about hepatitis B virus diagnosis and treatment. You know, vaccine, so we have already covered. It is having subunit or recombinant vaccine. And you know, subunit is HBsAg. Right, HBsAg. Right, so we have covered lab diagnosis. I will highlight here what we have covered. Very, very important, man. Lab diagnosis of hepatitis B, treatment of hepatitis B, vaccine of hepatitis B. Hepatitis B is very, very important. Right? Hepatitis B is very, very important. So with that, a 28-year-old lady, if you see the question, HBsAg is positive. Sir, HBsAg positive says infection is there. Okay, infection is there. Okay, next. IgM HBC is positive. Sir, IgM HBC positive says acute infection. Okay. IgG of HBS and IgG of HBE negative. Anti-HCV negative. What is the diagnosis? Sir, I want to highlight one more thing here. Anti-HCV negative. Right. Anti-HCV negative means it is not hepatitis C virus, it is hepatitis B virus. And hepatitis B virus, it is infection and acute. So answer is acute hepatitis B virus infection. Right, sir, very simple, straightforward answer. So easy, man. Right, so easy. And move on to the next question. A patient with multiple sexual partners manifested with fever and jaundice. Sir, jaundice means liver is involved, hepatitis. Right, HBsAg, so you see here HBsAg, HBeAg were positive, right? So it is hepatitis B virus hepatitis, high infectivity, because HBeAg positive, so high infectivity, you know, high infectivity. What is the treatment? Treatment is tenofovir for more than 54 weeks. More than 54 means more than 1 year. Tenofovir. Simple, man, you got the answer. Moving to the next question. Viral encephalitis. Right, we have covered viral hepatitis is over. So we are moving on to the viral encephalitis. Sir, now in viral encephalitis, many viruses causes encephalitis. I am talking about important viral encephalitis. That is, first you need to know. We are discussing important viral encephalitis. The important viral encephalitis I want to highlight. Viruses causing encephalitis affecting the basal ganglia. Is Japanese encephalitis virus. They're affecting the only temporal lobe. HSV1 virus, herpes simplex virus 1 virus. Sir, affecting only brainstem encephalitis. Sir, that is rabies virus. 3 important viruses causing encephalitis. JE, HSV1 and rabies. Many more are there, but these 3 are important. Right, JE affects basal ganglia of the brain. HSV1 temporal lobe of the brain. Rabies virus brainstem of the brain. Right? How will you diagnose? Sir, if you talk me how will you diagnose? Right? If you ask me how will you diagnose? Right? Japanese encephalitis virus IgM ELISA. Because viruses are diagnosed by antibody by ELISA. If you remember, all viruses are diagnosed by antibody by ELISA, but 2 viruses are to diagnosed by PCR. Herpes and corona. Diagnosed by PCR. Right, and 4 viruses are diagnosed by antigen: polio, rota, hepatitis B virus, and rabies virus. Right, sir, viruses are diagnosed by antibody detection or antigen detection or PCR. Remember this. We'll discuss in detail now only. But remember, viruses are diagnosed by antibody by ELISA or antigen by ELISA or PCR. JE virus has to be diagnosed by antibody, and herpes virus has to be diagnosed by PCR, and rabies virus has to be diagnosed by antigen. Sir, how to remember? I will tell you in some time. I will tell you. Before that, if you talk about the treatment, right, sir, usually viruses we don't have treatment except 4 viruses. Among these 4 viruses, herpes is one of them, which is having treatment. Hepatitis is one of them, tenofovir. Hepatitis, herpes, and HIV and influenza. These are the 4 viruses have treatment. Other viruses we don't have treatment. And if you talk about the vaccine, vaccine also we have already covered. JE virus is having live vaccine, SA14-14-2. Herpes simplex virus, no vaccine. And rabies virus, we have a vaccine, killed vaccine. And we have pre-exposure and post-exposure prophylaxis in rabies. So by taking the vaccine, we can prevent these diseases because we don't have treatment except for herpes. And this is how you diagnose. But the site affected in the brain, and the virus causing encephalitis. The lab diagnosis, and the treatment, and the vaccine. The vaccine. So all the important points are covered regarding viral encephalitis. Very, very important. 3 types of viral encephalitis. Many other viruses causes encephalitis, but they are important. And Japanese encephalitis virus is the most common virus or most common organism causing encephalitis. Japanese encephalitis is the most common causing encephalitis, affecting the basal ganglia. So now with this, if you see the questions on viral encephalitis, right, the questions which appeared in the previous exams, a patient presented with fever and bilateral temporal lobe inflammation involving only temporal lobe encephalitis. Man, just now we told temporal lobe is involved by HSV1. So answer is HSV herpes simplex virus. Very simple. HSV herpes simplex virus. Right. So a patient with fever, headache since 2 days. What is reliable test to diagnose HSV encephalitis? Sir, how will you diagnose HSV encephalitis? If you see here, I told you people, Japanese encephalitis virus antibody, HSV PCR, and rabies virus antigen detection. So PCR, HSV is diagnosed by PCR, and herpes simplex virus is a DNA virus, so DNA PCR, DNA virus, so DNA PCR. Right, simple, man. Moving to the next question, sir. So next question is human papilloma virus. Human papilloma virus. Human papilloma virus mainly causes right, skin disease. Mainly causes skin disease. And mainly causes warts. And warts, the most common area of the warts is anogenital area. And anogenital warts. Sir, we all know that human papilloma virus causes skin disease. Manifestation is warts in the anogenital area, which is also known as condyloma acuminata. And we all know it is caused by 6 and 11 serotypes. Okay, fine, ignore it. Why? So what is important in human papilloma virus is cervical cancer caused by human papilloma virus. How many serotypes cause cervical cancer? Sir, 6 and 11, right? 6 and 11, they can cause cervical cancer. 6 and 11, they can cause cervical cancer, but they have low risk. And so 16, 18, 31, 33, 45, 52, and 58, sir, all of them, they can cause cervical cancer. And they have high risk. So total 6, 11, 16, 18, 31, 33, 45, 50, 9 serotypes can cause cervical cancer. 9 serotypes. 9 serotypes can cause cervical cancer of human papilloma virus. 6 and 11, they have low risk. Remaining all serotypes, they have high risk. Among the high risk, the 16 and 18 are most common. Among the high risk, 16 and 18 are most common. And the proto-oncogenes responsible for the cancer is E6, E7 genes. I want to highlight, man, very, very important. Proto-oncogenes responsible for cervical cancer, E6, E7 genes. E6, E7 genes. Okay, so now which serotypes causes cervical cancer? 9 serotypes. How many serotypes? 9 serotypes. Which one having low risk? 6 and 11. Which one having high risk? Remaining all. Among them, which is most common? 16 and 18. Which are the proto-oncogenes? E6. Everything is important. Now, how will you prevent cancer? How will you prevent cancer? Very simple. Take the vaccine. What type of vaccine? Sir, vaccines so we have completed, man. Recombinant vaccine. No, L1 antigen. Go back and see 3 recombinant vaccines. 3 recombinant vaccines. One of them is HPV, human papilloma, L1 antigen. And L1 antigen of 16 and 18. L1 antigen of 16 and 18. Serotypes. Vaccine name is Cervarix. L1 antigen of 6, 11, 16 and 18. Vaccine name is Gardasil. Right? Vaccine name is Gardasil. Right, sir, Cervarix vaccine. Right, I'm telling Cervarix vaccine is bivalent. Bivalent means having only 2 serotypes. Gardasil vaccine is quadrivalent. Quadrivalent, having 4 serotypes. Gardasil 9 is nanovalent, having 9 serotypes. Sir, which is the best vaccine? Gardasil 9, because it is having all the 9 serotypes which causes cervical cancer. How many doses to take? 3 doses. First dose, second, 6, 3 doses. 0 to 6 months. 0 to 6 months means first dose is 0 dose. Second dose is after second month. After second month, after 2 months of first dose, and third dose is after 6 months of first dose, 3 doses. And when to take, sir, between 9 to 26 years of age. Between 9 to 26. Sir, who okay, again, right, who has to take? Only females. Okay, that don't say that males, because cervical cancer. The females between 9 to 18 years, they have to take 3 doses, 0 to 6 months. Better vaccine is Gardasil 9, having all the known serotypes which cause cervical cancer. And the vaccine is a recombinant vaccine containing the L1 antigen. Sir, everything is important, right? The overall cervical cancer, sir, that is which serotypes, most common, low risk, high risk, proto-oncogenes, vaccines, when to take, how many doses to take, which is the age group, everything is important. Human papillomavirus. Now, if you see the questions which have been appeared right recently in the previous exams, a person diagnosed to have anogenital warts with high risk of cervical cancer, high risk. Which strain of HPV is having high risk for cervical cancer? So they're just confusing us, giving anogenital warts, because anogenital warts means we jump to 6 and 11. Anogenital warts means we jump to 6 and 11. But remember, 6 and 11, they cause anogenital warts, no doubt in that. Also cause cervical cancer, but they have low risk. Ultimately, they are told high risk. High risk is, so 16, 18, 31, 33, 45, 52, 58, all are high risk. But among them, better is 16, 18, because they have high risk and most common. Therefore, the answer is HPV 18, high risk and most common. High risk and most common. Don't get confused by seeing anogenital warts, right? You may answer 6, right? But they're asking high risk of cancer. Though they have mentioned anogenital warts, high risk of cancer, 16 and 18. Sir, 40-year-old female died due to cervical cancer. A 40-year-old female died due to cervical cancer. What is the advice given to her 14-year-old daughter? Sir, is 14-year-old daughter between 9 to 26 years? Yes, what to do? Tell her to take the vaccine. How many doses? Sir, 0 to 6 months, 3 doses. Simple, man. Right? Tell her to take the vaccine. No need of gene detection, cervical biopsy. She is just 14-year-old. She is in the age group. To take the vaccine. Tell her to take the vaccine. She is prevented from cervical cancer. You got the question, man. Simple. So moving to the next. So next is, right, so dengue virus, right, clinical classification. Clinical classification. Okay, so if you talk about the clinical classification, right, clinical classification. Okay, so this is what you call it as probable dengue. Okay, this is means this one we call it as probable dengue virus infection. Right, probable dengue. Right, so this is what we call it as dengue with warning signs. Dengue with warning signs. And this is what you call it as severe dengue. This is what you call it as severe dengue. Right, so this is what they ask. When you can say probable dengue, when you can say dengue with warning signs, when you can say severe dengue. When you can say severe dengue. But this is what they ask. Okay, I will highlight here. Sir, if you get joint pains, okay, tourniquet test positive. Right, clinical manifestations. Tourniquet test positive. Leukopenia. Right, leukopenia. Then we call it as probable dengue. Right, probable dengue. Right, now here warning signs. Warning signs are persistent vomiting. Okay, then mucosal bleeding manifestations, bleeding, and decreased platelet count, and enlargement of liver. So these are the 4 important warning signs. Right, clinically 2. Remember 2 plus 2. Clinically 2 and lab diagnostically 2. Right, so clinically 2, persistent vomiting and mucosal bleed, enlargement of liver, more than 2 centimeter, and decrease in platelet. Warning signs. These are the 4 important. See, everything don't remember. Whatever I say, if you remember, I can tell you, you can answer. Right? So now simple, what is that? Sir, if you have joint pain, body pain, right, leukopenia and tourniquet test positive, probable dengue. But if you get bleeding manifestations and persistent vomiting, man, warning signs. Liver enlargement, decreased platelet count, warning sign. What is the what do you mean by warning sign? Warning sign that patient will go into severe dengue. But warning sign means warning sign that patient will go into severe dengue. Sir, severe dengue, sir, patient will go into shock. Patient will go into shock. And a dengue shock syndrome. Dengue shock syndrome. Severe bleeding, and because of severe bleeding only patient will go into shock. Because of severe bleeding only patient will go into shock, right? And here, you know, AST and ALT are elevated more than 1000. AST and ALT are elevated more than. So these are the 3 important signs you have to remember at the severe dengue, right? Severe dengue. So the severe dengue means, you know, man, if you remember the complication, dengue, hemorrhagic fever, and dengue shock syndrome. Dengue, hemorrhagic fever, and dengue shock syndrome. And liver enzymes are elevated. Liver enzymes are elevated. If there is patient is in the shock and patient in the hemorrhage, severe hemorrhage. Sir, here also I mentioned hemorrhage, but mucosal bleed, not severe hemorrhage. Severe hemorrhage, you see, remember the word spontaneous bleeding. Spontaneous bleeding, severe hemorrhage from the nose, internal bleeding. So simple, man, we have completed with the probable dengue, dengue with warning signs which will lead to severe dengue. Sir, probable dengue, I told, just remember body pain, tourniquet test positive, and leukopenia, that is decrease in WBC. If these 3 are there, probable dengue. Sir, persistent vomiting, mucosal bleed, 2 clinical signs, liver enlargement more than 2 centimeter, decrease in platelet count, right? Sir, these are the warning signs. So dengue with warning signs. What is warning? Warning that the patient is going into the severe dengue. Sir, if you talk about the severe dengue, right, if you talk about the severe dengue, sir, dengue hemorrhagic fever and dengue shock syndrome. Patient will go into shock. Dengue hemorrhagic fever with severe hemorrhage, severe bleeding, and finally AST elevated, AST, ALT, liver enzymes are elevated more than 1000. AST and ALT elevated more than 1000. So these is how we call it as severe dengue. Sir, very important, most commonly asked, probable dengue, dengue with warning signs. I have just simplified, right? I have just simplified. I have given 3 signs in probable dengue, 4 signs, warning signs, and 3 points in severe dengue. सर FMG देख सकते हैं क्या? मतलब समझा नहीं यार, FMG देख सकते हैं क्या मतलब? I did not understand. आपने तो इजी कर दिया सर, थैंक यू सर. सर 1 शॉट से कितना स्ट्राइक रेट आएगा वो सब लास्ट में यार, right? So dengue, probable dengue, dengue with warning signs, severe dengue. So with that, now coming to the lab diagnosis of viruses. Lab diagnosis of viruses by antigen detection. Lab diagnosis of viruses by antigen detection. See, 4 places are important where we have to detect antigen. 4 places are important where we have to detect antigen. Where we have to detect antigen. One is the stool sample may detect the antigen by ELISA. Blood sample may detect the antigen by ELISA. Sir, skin from the nape of the neck, saliva or CSF. Detect the antigen by DIF in these samples. And remember, skin from the nape of the neck is better than saliva, that is better than CSF. So detection of, and sir, that is important. First I want to highlight, we are talking about antigen detection. Okay, we are talking about, this is important, right? We are talking about antigen detection. Viruses diagnosed by antigen detection, right? Antigen detection in stool sample. Sir, in stool sample, polio and rota. Don't forget, antigen in stool sample, polio and rota. Antigen in blood sample. Antigen in blood sample. Don't forget, hepatitis B virus we have already diagnosed. Hepatitis B virus, HBsAg antigen, HBeAg antigen, and 3 antibodies. Sir, skin from the nape of the neck or saliva or CSF by direct immunofluorescence. Rabies virus. Rabies virus. Sir, 4 viruses which are very, very important where we diagnose them by detecting antigen, right? Antigen. सर FMG स्टूडेंट्स के लिए फायदा होगा क्या? 100% फायदा होगा, है ना? INS सेट का इज वेरी डिफिकल्ट फॉर FMG, बट नीट के क्वेश्चंस बहुत फायदा हो गया यार, वेरी इंपॉर्टेंट, राइट? बहुत फायदा होगा. बट ऑब्वियसली देयर आर फ्यू थिंग्स, बेसिक थिंग्स व्हिच इज आस्क्ड इन FMG, नॉट इन नीट. Those things are not covered. but 50% of the questions in NEET FMG are similar. 50% are similar, so फायदा होगा ही. There are a few basic things which are asked only in FMG, not in NEET. Those things are not covered, no, because this is previous year topics of NEET exam. But yes, 100% FMG को फायदा होगा, 50% फायदा होगा, 50% questions are same. So better to stick through this, even FMG students. Okay, next. Here itself I want to tell lab diagnosis of viruses. Lab diagnosis of viruses by PCR. By PCR. Right, lab diagnosis of viruses by PCR. Lab diagnosis of viruses by PCR. So remember two important viruses. I want to mention two important viruses. एक तो हमने देखा यार herpes virus. एक तो हमने देखा herpes virus. Coronavirus. Coronavirus. Again, I'm not telling these are the only viruses. I am again telling important viruses. Again, that is important. Right, I'm not telling only these. Important viruses diagnosed by antigen detection, important viruses diagnosed by PCR, important ones. There are many more, but these are important. And overall, this is very, very important. And overall, this is very, very important. Because other than this, most of the viruses are diagnosed by antibody detection. Most of the viruses are diagnosed by antibody detection. Okay, only few by antigen, only few by PCR, most of them by antibody detection. If you have any doubts with antibody, we do PCR. If you have any doubt with PCR, we do antibody. Right, but most of the viruses are diagnosed by antibody. So now lab diagnosis of dengue fever. Sir, dengue ka warning signs, everything you have seen. Right, lab diagnosis of dengue fever. Sir, if you talk about the lab diagnosis of dengue fever, sir, we have not covered dengue fever and dengue virus under antigen detection. We have not covered dengue virus under PCR. So when it is not covered under antigen detection and PCR, so obviously dengue virus is diagnosed by antibody detection. Dengue virus is diagnosed by antibody detection. Okay? Okay. Now, the very important thing what you need to understand is antibodies can be detected. Antibodies can be detected only 5 to 7 days after symptoms. That is important. Antibodies are detected only 5 to 7 days after symptoms. Yes, you detect antibody and you diagnose dengue virus infection, but after 5 to 7 days of symptoms. But what if the symptoms are within 5 to 7 days? Fever since 2 days, 3 days, dengue fever. You can't detect antibody because antibody can be detected after 5 to 7 days. So within 5 to 7 days, what you can do is detect the virus. What you can do is detect the virus. Detect the virus. Sir, how can I detect the virus? Do PCR, detect the virus, or do antigen detection, detect the virus, or do tissue culture, grow on culture, detect the virus. Sir, among these three, best is PCR. Best is PCR. Right, best is PCR. Antigen detection is having low sensitivity. Antigen detection is having low sensitivity. Sir, tissue culture is difficult. Tissue culture is difficult. Right, PCR is not that difficult and it is having good sensitivity. So that's why remember within 5 to 7 days PCR, after 5 to 7 days antibody. This is what you have to remember. Within 5 to 7 days. Okay, sir, confused between 5th day and 3rd day. Sir, within 5 to 7 days, PCR. If PCR is not there, antigen. If antigen is not there, tissue culture, but PCR. After 5 to 7 days, antibody detection. Simple. So with that, we have discussed now warning signs of dengue and severe dengue, probable dengue. Then lab diagnosis of almost all the viruses. We will detect antigen and PCR and then antibody. That I have told you in dengue. After 5 to 7 days, antibody. Within 5 to 7 days, PCR. So now moving on to the questions. Now HIV diagnosis also. Right. Sir, HIV diagnosis, if you see, again HIV diagnosis, if you see, have you covered under antigen? No. Have you covered under PCR? No. HIV is also diagnosed by antibody detection. HIV is also diagnosed by antibody detection. Right. So dengue virus is diagnosed by antibody detection by performing ELISA. Dengue virus is diagnosed by performing antibody detection by ELISA, but after 5 to 7 days of symptoms. Okay. Sir, now HIV virus also diagnosed by antibody detection, but by 3 rapid tests. Antibody detection by 3 rapid tests, not by ELISA. Rapid test, and you have to use 3 rapid tests. But the problem is, antibodies can be detected in HIV. Antibodies can be detected in HIV, right? After 3 weeks to 3 months of HIV entry. After 3 weeks to 3 months of HIV entry, right? This period is known as window period in HIV. This period is known as window period in HIV. What is window period? From the entry of HIV till you detect antibody is window period. From the entry of HIV till you detect antibody. Sir, what about NS1? Okay, what about NS1 means, man, NS1 is an antigen, no? NS1 is an antigen. NS1 antigen. I told you low sensitivity. Low sensitivity. Right, low sensitivity. Right. After 5 to 7 days antibody, within 5 to 7 days PCR. Antigen detection we can do, but low sensitivity. Low sensitivity means false negative results are possible. False negative results are possible. That's why better is PCR. Better is PCR. So now in HIV, you can detect antibody after 3 weeks to 3 months of HIV entry. That is window period. And in window period, you can diagnose by PCR. In window period, you have to diagnose by PCR, RNA PCR. RNA PCR. If you talk about congenital infection, sir, from the delivery of the baby, it takes 18 months. It takes 18 months to detect antibody. Within 18 months, a DNA PCR. Within 18 months, a DNA PCR. Okay, very important. Sir, in adults, we collect the blood sample. And we do RNA PCR within 3 weeks to 3 months of HIV entry. And after 3 weeks to 3 months, we go for antibody detection by 3 rapid tests. Sir, in congenital HIV infection, we collect dried blood spot. Right? We won't collect the direct blood. We take 1 drop of blood on a filter paper, dried blood spot. And we do PCR within 18 months of delivery, after 18 months antibody detection. Sir, now what I'm telling is, no doubt in that in dengue virus, we go for antibody detection. In HIV virus, we go for antibody detection. But when to go for antibody detection, that is what they ask in dengue virus and HIV virus. Very important. In dengue virus, we go for antibody detection after 5 to 7 days of symptoms. Within that PCR, RNA PCR, because it is a RNA virus. Right? RNA virus. But in HIV, 3 weeks to 3 months, antibody can be detected 3 weeks to 3 months of HIV entry. Right? Within that, RNA PCR. In congenital HIV infection, antibody detection after 18 months of delivery. Right? From where it is important, after 18 months of delivery, and within the DNA PCR. Sir, HIV may you can detect what? RNA and also DNA. Because HIV is a RNA virus, but it is having reverse transcriptase enzyme which converts RNA to DNA. Again P24 antigen पूछ रहे हो यार फिर से सेम स्टोरी बताना पड़ेगा आपको. चलो फिर से आपको सेम स्टोरी बताना पड़ेगा. क्या सेम स्टोरी बताना पड़ेगा? सर, RNA PCR is best. Otherwise P24 antigen. Otherwise P24 antigen. Again your P24 antigen is having low sensitivity. Antigen detection is having low sensitivity. P24 antigen is having low sensitivity. They are same like dengue, man. Same like dengue. कर सकते हैं P24 एंटीजन डिटेक्शन. डेंगू में भी NS1 एंटीजन डिटेक्शन कर सकते हैं, बट PCR बेटर है. राइट? लो सेंसिटिविटी है NS1 का. यहाँ पे भी P24 एंटीजन डिटेक्ट कर सकते हैं. राइट? कर सकते हैं, बट लो सेंसिटिविटी. दैट्स व्हाई PCR इज प्रिफर्ड. अडल्ट्स में RNA PCR, कंजेनिटल इन्फेक्शन में DNA PCR. राइट? एंटीबॉडी, सर एंटीबॉडी डेंगू में 5 to 7 days आफ्टर सिम्टम्स, HIV में 3 weeks to 3 months after HIV entry, and in congenital HIV infection 18 months after delivery. Within that तो सबको PCR. Antigen we can detect but low sensitivity. Right? Antigen we can detect but low sensitivity. Right? Sir, God of micro. Sorry, I won't accept I'm God of micro. Sir, I'm also a student learning like you people. Just I'm teaching from past 5 to 7 years, so I have little better experience. That's it. Otherwise, you know, right? Everything This microbiology is like an ocean. Tamim sir same. Medicine is like an ocean. Similarly, every subject is like an ocean. What I know is just one drop. This is Tamim sir's what they say. Tamim sir's dialogue. Right? Medicine is like an ocean. What I know is just one drop, and what I don't know is the entire ocean. Similarly, microbiology is an ocean, and what I know is only one drop. The rest everything. There are a lot which I don't know. I'm also a student like you learning. I can just teaching you microbiology because from past 7 years I have a little experience of teaching microbiology. Okay, so with that, now we have to move on to questions. Sir, what and all we have discussed now is warning signs and severe dengue, probable dengue. After that, lab diagnosis of viruses is the where we have concentrated, right? So now I have given 4 places where we detect antigen detection, 2 places where we do PCR, and 2 places where we go for antibody, right? I can put this headline: lab diagnosis, important lab diagnosis of viruses by antibody detection. Miss you, sir. Okay, thank you. Miss you too. Okay, I want to highlight antibody detection. Antibody detection, and not 2. One is dengue and one is HIV. When to detect antibody, that is important. So with that, now if you see the questions, guys, a 50-year-old man in Delhi, fever, headache, joint pain, petechial rash and bleeding gums, right? Sir, viral fever associated with hemorrhage, viral hemorrhagic fever. Blood platelet count is 20,000. Sir, platelet is decreased. Dengue fever with warning sign. Right. Sir, joint pain, petechial rash, bleeding gums. So viral fever associated with hemorrhage, viral hemorrhage fever. Platelet is decreased, it is a warning sign. Dengue fever with warning sign. So answer is dengue. Simple, man. Platelet is decreased. Dengue. Simple question. Next, a 4-month-old infant which was born to a HIV positive mother, 4-month-old. Okay, 4-month-old HIV positive mother presented with diarrhea. What is the next step? Sir, 4-month-old, what you will do? In 4-month-old child? I told you after delivery up to 18 months. PCR. I know. Sir, HIV antibody after 18 months. So this is within 18 months. Okay, within 18 months. ERT should be started after diagnosis. Without diagnosis, how will you start ERT? Antiretroviral therapy, that is treatment of HIV. How can you start? Without diagnosis. First you have to diagnose, then you have to start. Right? So answer is PCR, because within 18 months. Okay, next question. Which is the best investigation for the diagnosis of rotavirus? And just now we have discussed. I'm going to show you antigen detection. Right? Antigen detection. There is the antigen detection here. Antigen detection. Polio and rota, stool, ELISA. Antigen detection of polio, rota in the stool sample. Sir, polio and rotavirus antigen, stool sample, rotavirus antigen detection. You got the answer. Okay, so these are the questions from lab diagnosis of. Okay, hello everybody, welcome back. Okay, sorry for that. Laptop got rebooted automatically, suddenly. Usually it will not happen. Don't know. Right? Interfered with our class. Suddenly it got switched off and got rebooted. Right? But hope we are live now. Hope everything is fine. Hope interfered with our class. Okay. So with that, we were discussing rotavirus. The best investigation for the diagnosis of rotavirus. I told you stool antigen detection. Okay, next topic. So next topic is congenital infections. Right? Next topic is congenital infections. Right. There are many organisms causing congenital infections. Important organisms I want to highlight: Treponema pallidum, rubella, and toxoplasma. Treponema pallidum, rubella, and toxoplasma. HSV2, varicella, zoster and cytomegalovirus. Parvovirus, Zika virus, and hepatitis B, C, D virus. 3 plus 3 plus 3. 9 important organisms causing congenital infection. 9 important organisms causing congenital infection. And why I have arranged the 3 plus 3 plus 3? Because, sir, these three they have triads. These three they have triads. And these three are herpes viruses. These three are herpes viruses. And these are other viruses. Other viruses. Sir, I have arranged in such a way that first viruses, not viruses, sorry. Yeah, you can say viruses. Viruses with triads. Or you can say organisms with triads. Organisms with triads. Organisms with triads. And then herpes viruses. 3 important herpes viruses which causes congenital infection. Other viruses causing congenital infection. Okay, other viruses causing congenital infection. Now start with the triads. All the triads they start with the I. All the triads they start with the I. All the triads. Sir, miss the tone of your voice. I can't read micro with a straight tone now. Okay. So with that, all the triads they start with I. Start with I. Okay. Now remember one thing I want to tell you people. What is that? So Treponema pallidum is a bacteria. Rubella is a virus. Toxoplasma is a parasite. That you should not forget. Okay. So that also I will want to write down: bacteria, virus, and parasite. All of them they affect the eye. First manifestation is eye manifestation. Right. First manifestation is eye manifestation. So eye manifestation, if you observe, the question is how to remember. Question is how to remember. यार बहुत ही simple बताता हूँ. Treponema pallidum keep in front of the eye. In front of the eye, what is there? Cornea. So keratitis. Rubella keep in the middle of the eye. Middle of the eye, what is there? Lens. It causes cataract. Toxoplasma keep in the back side of the eye. Back side of the eye, what is there? Inner layers of the eye, chorion and retina. Inner layers of the eye, chorion and retina. Very simple, man. Right? इस तरह से याद रखो. Very easy to remember. Right? In front of the eye, cornea. Middle of the eye, lens. Back side of the eye, chorion and retina. So in front of the eye, keratitis. Middle of the eye, cataract. And back side of the eye, chorioretinitis. बस बैक्टीरिया को आगे रखो, वायरस को बीच में और पैरासाइट को पीछे. And that is how we read also. No, bacteria is our favorite. Next is viruses. Last is parasites. The way we read, in the same way you have to keep it. In the eye, eye may in front you keep Treponema pallidum. It affects cornea, causes keratitis. Virus you keep in the middle. Rubella virus, middle mein there is lens. It causes cataract. Back side of the eye, chorion and retina. Inner layers of the eye, chorioretinitis. You keep the parasite toxoplasma. Easy to remember eye manifestations. Not only I have given what are the eye manifestations, I have told you how to remember the eye manifestation. Abhi ear. Sir, Treponema pallidum goes to ear, rubella goes to the ear, parasite won't goes to the ear. Right? Sensory neural hearing loss. Right? Abhi, this is also easy to remember. Which one goes to the ear? The ones which come down, they goes to the ear. See, Treponema and rubella, they start with the eye, they go to the ear, right? And they come down to heart. Right? Come down to heart. Rubella. Start with the eye, go to the ear, come down to teeth. Treponema pallidum बहुत ही आसान है यार. सर आंख से शुरू होके कान में जाके टीथ में आ जाता है तो Treponema pallidum. आंख से स्टार्ट होके कान में जाके दिल में उतर जाता है, ये है रूबेला. आंख से डायरेक्ट ऊपर चला जाता है ब्रेन पे. From the eye directly into the brain. Right? Brain random calcifications and hydrocephalus, toxoplasma. Now, this is how you have to remember the triads. All the triads start with the eye. Keep Treponema in front of the eye, rubella in middle of the eye, toxoplasma backside of the eye to remember the eye manifestations. And remember the triads which come down to teeth, come down to heart, they go to the ear and they come down. And the one which goes above, directly goes to above to the brain. है ना, ऊपर जाने वाले डायरेक्ट ऊपर चले जाते हैं ना. इसी तरह से टॉक्सोप्लाज्मा डायरेक्ट ऊपर. कहाँ पे? ब्रेन. आई से डायरेक्ट ऊपर ब्रेन. ब्रेन में ब्रेन रैंडम कैल्सिफिकेशंस इन द ब्रेन एंड हाइड्रोसेफेलस. ये रैंडम कैल्सिफिकेशन है, दिस वर्ड इज इंपॉर्टेंट. This random word is important. Random calcification. Why? Because next we go herpes simplex virus 2 varicella zoster cytomegalovirus. सर यहाँ पे हम हाईलाइट करेंगे पेरीवेंट्रिकुलर ब्रेन calcifications, right? Sir, periventricular calcifications in the brain, right? Calcifications only surrounding the brain, right? Calcifications only surrounding the brain, right? Only surrounding the brain. Here topic पे रहो. The topic is microbiology. Okay, in the comments I request you please be on the topic, right? Periventricular calcifications, diffuse calcifications, random calcification, toxoplasma, only calcification surrounding the ventricles, periventricular calcifications are cytomegalovirus, right? And then sir, psychiatrization and limb hypoplasia. Psychiatrization, right? Psychiatrization means skin scars. Psychiatrization means skin scars. Limb hypoplasia means short limbs, short hands, short legs. Varicella zoster virus. There are vesicles and meningitis. Vesicles means fluid filled lesions, you know, herpes simplex virus 2, vesicles and meningitis. Parvovirus, non-immune fetal hydrops. Non-immune, that is important. Non-immune is important because immune fetal hydrops is seen with erythroblastosis fetalis or Rh incompatibility. Zika virus, microcephaly, small head. Micro means small, head micro is small, head is head, cephaly means head, microcephaly small head. Sir, hepatitis B, C, D, sir, jaundice. All the important organisms causing congenital infection. Very, very important, man. 100 stars, right? Everything is 100 stars. Whatever we're discussing today, and important topics. Very, very important. Right? Very, very important. Okay, best trick to remember, sir. Now I will never forget, sir. Yeah, thank you, man. I know we always get confused. We always get confused. So remember, the one which goes above directly goes above. From the eye directly to the brain. The one which comes down, they go to the ear and they come down. Eye to ear to teeth. Eponema, eye to ear to heart. So rubella थोड़ा ज़्यादा ही नीचे उतर जाता है. दिल में आ जाता है rubella. दिल में आ जाता है. चलो, you got all the congenital infections and their manifestations. Now, which is the most common among all these? Which is the most common organism? Pete's one portion is done here only. Thank you, sir. Now, sir, which is the most common organism causing congenital infection? Remember, cytomegalovirus is the most common organism. Most common organism. Least common organism. HSV2 is the least common organism. Okay, highlight this point. Least common, most common. Because most common, least common, both are herpes. Most common is also herpes. Which herpes? Cytomegalovirus. Least common is also herpes. Which herpes? Herpes simplex virus. Okay? But if they ask, which is the most common? Which is the most common? In first trimester. Which is the most common? In first trimester. Rubella. Rubella. Yeah, these points are important. These points are very, very important. I will highlight these points. Okay, I will highlight these points. So least common, okay, most common, right? Most common, least common, and most common in first trimester. Okay, so most common organism is cytomegalovirus. Least common organism is herpes simplex virus 2 causing congenital infection. But most common, particularly in first trimester, if they ask, most common in first trimester, it is not cytomegalovirus, it will become rubella. Overall, most common is cytomegalovirus, but specifically in first trimester, it is rubella. Right? It is rubella. Okay, sir, with that, now if you see the questions on congenital infection, sir, congenital infection with hearing loss, cataract, and PDA, patent ductus artery, dil mein utar gaya yaar, rubella. Right, rubella. Right, rubella. Rubella. Right, thank you for the best tricks, sir. Welcome, man. Right, my class is full of tricks. If you have not attended, you can ask the students who have attended. There are preterm child with cataract, sensory neuron, periventricular calcifications. I want to highlight this. What? Periventricular calcifications. So calcifications only surrounding the ventricles. Right, cytomegalovirus. Ignore other points. Sensory neural hearing loss, cataract. Isko ignore karo. Hota hai, but we have not discussed. We discuss only important. Periventricular means 100% cytomegalovirus. So next stop, sir, with that virology is over, sir. General microbiology is over, bacteriology is over, virology is over. Moving on to the parasitology. Sir, parasitology. Parasitology means, sir, say parasitology, mycology. Sir, we are not taking along. Sir, bacteriology was the vast subject. Virology was the next vast. Next, parasitology, mycology. It will get over very soon. Sir, blood and tissue flagellates. Blood and tissue flagellates. Sir, flagellates means protozoa with flagella. Flagellates means protozoa with flagella. The flagella which are having protozoa are known as protozoa. Blood and tissue means the one which affect blood and tissue. The protozoa which affect blood and tissue. Blood and tissue flagellates. Sir, kitne hai blood and tissue flagellates? We have 2 blood and tissue flagellates. Sir, which are the 2 blood and tissue flagellates? And those are the ones what we are seeing, man. One is Leishmania and one more is Trypanosoma. Trypanosoma may we have Cruzi and Trypanosoma may we have Brucei. So these are the right 2 blood and tissue flagellates. And sir, Leishmania is transmitted by sandfly. Leishmania is transmitted by sandfly. It causes a disease, Leishmaniasis. It causes a disease, Leishmaniasis. Right? And diagnosis is Sir, blood and tissue protozoa are diagnosed by, right? Remember peripheral blood smear. Diagnosed by peripheral blood smear. Peripheral blood smear. Okay. What do you see in the peripheral blood smear? Leishmania and Trypanosoma. So Leishmania is present within macrophage. Leishmania is present within macrophage. And it is a round-shaped organism with kinetoplast. Round-shaped organism with kinetoplast. Containing RK39 antigen. Okay, so diagnosed with Leishmaniasis. See what you are seeing here. So this is macrophage. This is macrophage. This is nucleus of macrophage. That is nucleus of macrophage. And what you see here is a small round. That is Leishmania. That is Leishmania, right? A round structure. And another small, right? Small structure attached. That is kinetoplast. Kinetoplast. Sir, kinetoplast is a structure which is present only in Leishmania. Right? Kinetoplast is a structure which is present only in Leishmania, and it is always, Leishmania is always present within macrophage and RK39 antigen positive. Right? I will highlight kinetoplast and RK39 antigen, and I will highlight the sandfly. Right? These are the 3 things which are important to remember. Now, Trypanosoma cruzi and Trypanosoma brucei. Right? Trypanosoma cruzi and Trypanosoma brucei. Cruzi is transmitted by Redovik bug, brucei is transmitted by Sessy fly, and cruzi causes Chagas disease, brucei causes sleeping sickness. Right? And Trypanosoma is identified by folded flagella. Spindle shaped structure with folded flagella. ये देखो ये जो structure है ना, spindle shaped structure. This is Trypanosoma. This is Trypanosoma. And how to identify? Sir, this flagella, man. ये देखो ये जो flagella है ना, folded flagella. Folded flagella. That's how you identify. Spindle shaped organism with folded flagella. Trypanosoma. Cruzi or brucei. How can you say? You can't say cruzi or brucei. दोनों एक ही जैसे दिखेंगे. Both of them they look same. Cruzi and brucei because both are Trypanosoma. So this is how you identify Leishmania and Trypanosoma. So Leishmania round shape with kinetoplast within macrophage, RK39 antigen positive. Folded flagella Trypanosoma. The Trypanosoma cruzi, Chagas disease and Redovik bug, brucei, sleeping sickness and Sessy fly, and they have folded flagella. That's how to remember. Right? Cruzi, brucei, if you get confused, I always tell students, remember, brucei, C, ends with the pronunciation C. Sessy fly, C, sleeping sickness, C. जहां पे भी C आएगा तो उसको brucei, Sessy fly, sleeping sickness याद रख लोगे. So cruzi तो automatically you know, cruzi, Redovik bug, Chagas disease, no need to remember. If it is not brucei, then it should be Sessy. How to identify brucei? Brucei identified by Sessy, brucei, Sessy fly, sleeping sickness, right? Folded flagella. So these are the blood and tissue flagellates. Leishmania and Trypanosoma. Right. Now moving on to the blood and tissue Sporozoa. Moving on to what? Blood and tissue Sporozoa. Blood and tissue Sporozoa. Sporozoa means, right, sir, protozoa which are non-motile. Protozoa which are non-motile, affecting blood and tissue. Obviously here also we take peripheral blood smear. Here also we take, how many are there? 3 are there. So totally I'm telling we have 5 blood and tissue protozoa which affect blood and tissue. Out of these 5, 2 are having flagella and 3 are non-motile. 3 are non-motile. 2 flagellates are Leishmania and Trypanosoma we have completed. Now we are seeing the non-motile blood and tissue protozoa, that is Sporozoa. Sir, non-motile ones are Plasmodium vivax and Plasmodium falciparum, and Babesia and Toxoplasma. You know, Plasmodium is transmitted by Anopheles mosquito. Babesia is transmitted by tick, whereas toxoplasma is transmitted by fecal-oral route from cat. Toxoplasma is present in the cat, shed in the cat species, and acquired from fecal-oral route. And you know the disease, Plasmodium causes malaria, Babesia causes babesiosis, Toxoplasma causes toxoplasmosis. Toxoplasma causes toxoplasmosis. Toxoplasmosis. Okay? Okay, now. The sporozoid. Oocyst containing sporozoids. Sir, sporozoids are the infective forms. Sporozoids are the infective forms. They infect humans in the form of sporozoids. Right? All of them, they infect humans in the form of sporozoid. Sporozoid is the infective form. They enter humans in the form of sporozoid. Toxoplasma also enter in the form of sporozoid, but sporozoids are present within the oocyst for toxoplasma. Sporozoids are present within the oocyst. And once they enter, they cause blood and tissue infection. And once they cause blood and tissue infection, we take the peripheral blood smear. And once you take the peripheral blood smear, you will identify. And whatever you see here, these are the diagnostic forms. Whatever you see here, these are the diagnostic forms. The forms in which they come in the peripheral blood smear and that help us to diagnose. That will help us to diagnose. So what is this? Round shaped gametocyte. If you see round shaped gametocyte, round shape with blue color dots, vivax. Banana shaped gametocyte. Right? Banana shaped gametocyte. Banana shaped falciparum. Maltese cross. Right? Maltese cross. Maltese cross. Cross shape. Maltese cross. Toxoplasma. If you say spindle shape. Spindle shape. Tachyzoids. Right? Spindle shape. Tachyzoids. I say Maltese cross. Merozoids. Okay, so what is important here is round shape, banana shape, Maltese cross, cross shape, spindle shape, spindle shape. What do you see? Round shape, gametocyte, banana shape, gametocyte, Maltese cross, merozoid, spindle shape, tachyzoids. These are the diagnostic forms. This is how you diagnose. These are the infective forms. Sir, blood and tissue sporozoa in front of you. Sir, we love your teaching. Thank you. Right, thank you. Okay, sir, you know the infective forms, you know the diagnostic forms. So this is how you diagnose vivax, falciparum, babesia, and toxoplasma. Right, toxoplasma. Right, sir, vectors are important. Vectors are important. Sir, this is vector, है ना? इसको रब कर दें. This is vectors. Vectors are important. Infective forms are important. Diagnostic forms are important. Vectors, infective form, and diagnostic form. Right, infective form and diagnostic form. So blood and tissue protozoa are over. Blood and tissue flagellates and blood and tissue sporozoa. 5 protozoa affecting blood and tissue. See the questions. A man from Bihar with fever and skin lesions. On microscopy. Organism with kinetoplast. Man, kinetoplast. Kinetoplast seen in only one organism, Leishmania. Kinetoplast is seen in only one organism, Leishmania. And the disease is cutaneous leishmaniasis. You see, disease is cutaneous leishmaniasis. Cutaneous leishmaniasis. Right, which is also known as Delhi boil. Right, which is also known as Oriental sore. Which is also known as Baghdad button. Cutaneous leishmaniasis, Delhi boil, Oriental sore caused by Leishmania tropica, fever and skin lesions, Leishmania tropica, whatever it is, man. Organism with kinetoplast. Simple, man. Leishmania. No other organism contains kinetoplast. A patient presented with fever and hepatosplenomegaly. Bone marrow smear demonstrated macrophages containing parasites with kinetoplast. Here, कितनी बार repeat हुआ है देखो यार. Right, in 3 to 5 years, 2 times repeated, but question asked is different, and that is what I told. PYQs won't get repeated. PYQ topic gets repeated. Previously they asked the organism. Now in this they are asking the vector. What is the vector? You know, vector for Leishmania, sandfly. Sir, a patient presented with hepatosplenomegaly. On examination, pallor was present. pallor was present. HRP2 antigen positive. Okay, we forgot to mention antigen. We forgot to mention antigen. Go back. Go back. We forgot to mention antigen. Yeah, we have mentioned, and I forgot to discuss. Okay, I forgot to discuss. No, the PLDH antigen is present in Vivax. PLDH and HRP2 antigens are present in falciparum. Right, we have written. I forgot to mention. Right, remember 3 antigens. Very very important. RK39 antigen. RK39 antigen in Leishmania. RK39 antigen in Leishmania. Right, PLDH antigen. Right, PLDH antigen in Vivax, PLDH and HRP2 antigen in falciparum. Sir, PLDH is present in both Vivax and falciparum. Okay, HRP2 is present only in falciparum. HRP2 is present only in falciparum. Okay, so with that, now if you see the question, sir, hepatosplenomegaly HRP2 antigen, HRP2 is found only in falciparum. HRP2 is found only in falciparum. Right. Okay, now, sir, protozoa are over. Moving on to the helminths. Helminths means cystodes. Cystodes. Especially cystodes causing tissue infection. Sir, how many cystodes causes tissue infection? Only 2 cystodes causes tissue infection. Only 2 cystodes. Sir, which are the 2 cystodes that causes tissue infection? The 2 cystodes that causes tissue infection are Taenia solium and Echinococcus granulosus. Right, these are only 2 cystodes which causes tissue infection. Remaining all cystodes, they cause intestinal infection. Right, cystodes affects only 2 sites, intestine and tissue. These are the only 2 that affects tissue. The tissue infection of Taenia solium is known as cysticercosis, and the tissue infection of Echinococcus is known as hydatid cystic disease. Right, which tissues are affected? Taenia solium affect muscle, eye and brain. And that's why we have muscular cysticercosis, ocular cysticercosis, and neurocysticercosis. The neurocysticercosis manifest with seizures. So this is the MRI brain picture. This is the MRI brain picture. Right, where you see multiple cysts. The MRI picture where you see multiple cysts, containing protoscolex. That is not important. Multiple cysts in the brain. Neurocysticercosis. Right, and radiological diagnosis is preliminary diagnosis. Final diagnosis is demonstrate the egg in the stool sample. How will you identify the egg? Sir, if you see a egg which is having this, outer thick brown color margin, what is this? See this outer thick brown color margin. If you see an egg with outer thick brown color margin, identify Taenia egg. What do you call this outer thick margin? Sir, we call this outer thick margin as embryophore. Right, embryophore. I will highlight this embryophore. What is embryophore? Outer brown thick margin. And the only egg which is having embryophore is Taenia egg. And Taenia egg, if it is non-acid fast, so it is solium. If it is non-acid fast, it is solium. Because Taenia sagenata egg is acid fast. Because egg of solium and sagenata look same. Both are having embryophore. If it is non-acid fast, solium. If it is acid fast, sagenata. And Taenia solium is the one which causes cysticercosis. And that's how you diagnose cysticercosis. Okay. So neurocysticercosis is very important for entrance exam. How will you diagnose neurocysticercosis? So neurocysticercosis is diagnosed by MRI brain, where you see multiple cysts. And final confirmation is seeing egg in the stool sample. And final treatment is first start steroids, then albendazole. So this is the first cystode tissue infection, right? Cystode tissue infection, right? Cysticercosis. Second cystode, Echinococcus granulosus. Tissue infection is hydatid cystic disease. Sites affected are liver and lung, right? Hepatic hydatid cystic disease, pulmonary hydatid cystic disease, liver and lung. Most common site is liver. Here also cysticercosis, most common site is muscle, not neurocysticercosis. Muscle is most common site. Echinococcus is liver is the most common site. Why the disease name is hydatid cystic disease? Because you see the formation of hydatid cysts. you see the formation of hydatid cyst in the liver and lung. And again you have to do CT abdomen. Again you have to do CT abdomen. Then antibody by ELISA. Right? Because remember one thing, radiological diagnosis is preliminary diagnosis, not final. And that's why neurocysticercosis, after doing MRI brain, you have to demonstrate egg in the stool sample. Similarly, in hydatid cystic disease, after demonstrating the hydatid cyst, you have to detect antibody by ELISA. Antibody by ELISA. Not the egg of Echinococcus, because egg of Echinococcus is seen in dog. It is dog tapeworm. Egg of Echinococcus seen in dog, not in man. As egg is not seen in man, we have to diagnose by antibody detection by ELISA. And radiologically, if you do CT abdomen, in the liver you see hydatid cyst. So this is the hydatid cyst. This is the hydatid cyst. Inside the hydatid cyst, if you see, right, the inner membrane of the hydatid cyst is detached. The inner membrane of the hydatid cyst is detached and floating inside. What is this? So this is detached inner membrane of hydatid cyst, and somebody imagine it as a lily flower in water, and this person called it as water lily sign. Water lily sign. Sir, water lily sign means like lily flower in water. And this person imagine, sir, in hydatid cyst, sometimes what happens? Inner layer gets detached and will be floating inside the hydatid fluid. The detached inner membrane floating inside the hydatid fluid, somebody imagined it as lily flower floating in the water lily sign. So imaging me, you are seeing hydatid cyst with water lily sign. Preliminary diagnosis, final diagnosis, antibody by ELISA diagnosed. Then once you have diagnosed, okay, once you have diagnosed, remember, you have to do PAIR, percutaneous aspiration, injection, reaspiration, right? And start albendazole. Sometimes PAIR will not work, then go for surgery. Sir, you have to go for surgery only if PAIR fails. Remember, we have to do PAIR. Without doing PAIR, you should not go for surgery. If patient get cured with PAIR, no need of surgery. Patient is not getting cured with PAIR, then only have to go for surgery. FNAC, this, that, nothing should be performed. Hydatid fluid is anaphylactic. Only PAIR is permitted. Do PAIR, and you have to do PAIR. And first to do is PAIR. If PAIR fails, then only you have to go for surgery. Otherwise, you should not go for surgery. And after that, you can start the treatment albendazole. Sir, these are the cystodes that affect the tissue. Only two cystodes affect the tissue: Taenia solium and Echinococcus. Tissue infection by Taenia solium is cysticercosis, affect muscle, eye, and brain tissue. And tissue infection by Echinococcus, hydatid cystic disease, affects the liver and lung, and you see the formation of hydatid cyst. And both the places you do radiological diagnosis. Remember, radiological diagnosis is preliminary diagnosis, and that's why you have to detect the egg in the stool sample for Taenia solium for final diagnosis, antibody by ELISA in Echinococcus for the final diagnosis, because Echinococcus may egg is seen in the dog, not in man. And finally, treatment. Sir, both of them drug of choice is albendazole. But in Taenia solium neurocysticercosis, first you have to start steroids, then only albendazole. In Echinococcus, first you have to do PAIR. If PAIR fails surgery, then only albendazole. Sir, very simple, right? Very simple. Okay, how to remember grade? Man, grade and all not important. Neuros, forget it off. You just remember what I have told. See, past 7, 10 years of questions, right? What is important? You have to remember that much. There are 53-year-old patient presented with abdominal pain. CT scan showed the following. Sir, abdominal pain. This is CT scan showed the following finding. CT scan is showing water lily sign. CT scan is showing water lily sign. The disease is hepatic hydatid cystic disease. Hepatic hydatid cystic disease. Okay, fine. Sir, what they're asking is, right, which of the following is true statement? You just have to remember. They're asking which of the following statement is true. Okay, caused by Echinococcus. Yes, true. Simple, man. Directly got the answer. So simple question. Right, so simple question. Surgery is mandatory. False. PAIR has to be done. FNAC can be done. False. PAIR has to be done. Angioembolization can be done. False. PAIR has to be done. PAIR karna hai, or surgery is not mandatory. First you have to do PAIR. So caused by Echinococcus. True statement. Simple, man. Got the answer. Okay, next, parasites causing cancer. So next topic, parasites causing cancer. Parasites causing, okay, sorry. Yeah. Next topic, sir, parasites causing cancer. And remember, cancer is caused by trematodes. And remember, cancer is caused by trematodes. So cystodes are over, we have gone to trematodes. Cystodes are over, we have gone to trematodes. So there are only 3 cancers seen in parasitology. In entire parasitology, only 3 types of cancers are seen: bladder cancer, colon cancer, cholangiocarcinoma, and hepatocellular carcinoma, and greater than symbol, because cholangiocarcinoma is more common than hepatocellular, and cholangiocarcinoma means bile duct cancer. Bile duct cancer. So bladder cancer is caused by Schistosoma hematobium. Colon cancer is caused by Schistosoma japonicum. Cholangiocarcinoma, hepatocellular carcinoma is caused by Clonarchis sinensis and Opisthorchis, and remember, Clonarchis sinensis is most common. And remember, facial hepatica won't cause cancer. This you have to fix in your mind. Space, right? Facial hepatica won't cause cancer. Only trematodes causes cancer. Right? And these are the trematodes: Schistosoma hematobium, Schistosoma japonicum, Clonarchis, and Opisthorchis. Hematobium, bladder cancer; japonicum, colon cancer; Clonarchis and Opisthorchis, cholangiocarcinoma, and hepatocellular carcinoma. Cholangiocarcinoma is most common. Right? Moving on to the questions. Sir, Clonarchis sinensis associated with which carcinoma? Very simple, man. Cholangiocarcinoma. Straightforward question. Okay, next topic. Trematodes causing tissue infection. Right? Cystodes causing tissue infection we have covered. Now we are covering the trematodes causing tissue infection. Sir, sorry. Once again, that was okay. Nah, thank you guys. Okay, that was not trematodes, guys. I'm sorry. We are talking about, right? Cystodes are over, trematodes are over. Now we are moving on to the nematodes. Okay. Now we are moving on to the nematodes. Okay, nematodes. Okay, nematodes causing tissue infection. Right. So there are 3 nematodes which causes tissue infection. There are 3 nematodes which causes tissue infection. Sir, which are the 3 nematodes causing tissue infection? Aja yaar. Okay, thank you. Okay, which are the 3 nematodes that causes tissue infection? Sir, filarial worms. Filarial worms causes tissue infection. Then Trichinella spiralis and Dracunculus medinensis. Filarial worm, Trichinella spiralis, and Dracunculus medinensis. Filarial worm, Trichinella spiralis, and Dracunculus medinensis. Okay, these are the 3 nematodes which causes tissue infection. Which are the tissues affected? Filarial worm affects lymphatic tissue and subcutaneous tissue. That's why it causes lymphatic filariasis and subcutaneous tissue filariasis. How will you diagnose? DEC provocation test. Right? And do DEC provocation test. Collect the peripheral blood smear, and in the peripheral blood smear demonstrate the microfilarial larva. Right? Very, very important. I want to highlight this. Right? DEC provocation test you have to do. After doing that, collect the peripheral blood smear, and in the peripheral blood smear you have to look for the microfilarial larva. Microfilarial larva. Right? If the microfilarial larva is not having nuclei in the tail tip, but there is a sheath surrounding the larva, it is Ucheraria. No nuclei in the tail tip and there is a sheath, Ucheraria. No nuclei in the tail tip and there is no sheath, Onchocerca. Right? So tail tip is having 2 nuclei and also sheath, Brugia malai. Tail tip is having nuclei and also sheath, Salloa. See, first thing what you need to remember is, sir, first 2, that is Ucheraria and Brugia malai, they affect lymphatic tissue, they cause lymphatic filariasis. And next 2, they affect subcutaneous tissue and they cause subcutaneous filariasis. Right? Subcutaneous filariasis. And the most common is Ucheraria. Most common is Ucheraria. Remember Ucheraria. See, first of all, if you observe sheath is there for all. But sheath is not there only for Onchocerca. Right? Sheath is not there only for Onchocerca. Nuclear also not there for Onchocerca. Sheath is also not there, nuclear also not there, Onchocerca. Okay, remaining 3 they have sheath. When they have sheath, no nuclei. Sheath is there, nuclei not there, Ucheriaria. Sheath is there, 2 nuclei are there, Brugia, and sheath is there, nuclei are there. So it is right, Loa. Sheath is there, nuclei are not there. Right? Divide with sheath, without sheath. Sir, without sheath is only one onchocerca, done with onchocerca. And you know, onchocerca is different. Onchocerca is different. Why onchocerca is different? See, the treatment is ivermectin. Treatment is ivermectin. What we have studied, treatment for filarial worm is DEC. Yes, treatment for filarial worm is DEC. All the filarial worms treatment is DEC, but onchocerca treatment is ivermectin. Remember, onchocerca is different. Onchocerca is different. Treatment is ivermectin. And also no nuclei, no sheath. कुछ भी नहीं है. No nuclei, no sheath. Easy to remember. And no sheath in the tail tip. No nuclei in the tail tip. Sir, जब onchocerca को separate कर दिया, so remaining is 3, Ucheriaria, Brugia malae, and Loa. All of them they have sheath. So you have to differentiate only based on nuclei. Sir, sheath is there, nuclei is not there, Ucheriaria. Sheath is there, only 2 nuclei are there, Brugia malae. Sheath is there, full multiple nuclei are there, Loa. Right? Simple. Divide no sheath and sheath. Then you try to understand. No sheath is separate. Onchocerca treatment is also separate. Filarial worm. First nematode that affect the tissue. Okay. Sir, moving to the next 2 nematodes that affect the tissue. Trichinella spiralis affect which tissue? Muscle tissue. Muscle tissue. So Dracunculus medinensis affects skin tissue. And a filarial worm affects lymphatic tissue and subcutaneous tissue. Whereas Trichinella spiralis affect muscle tissue, manifest with myalgia and myocarditis. Dracunculus medinensis affects skin tissue, manifest with skin blisters. How will you diagnose? Sir, how will you diagnose is very important. Attachment test positive, otherwise muscle tissue biopsy. The muscle tissue biopsy, you see, in the muscle tissue biopsy, if you see spiral larva, sir, diagnosed, drug of choice is albendazole. Right? Sir, skin blisters, demonstrate the adult worm. Right? Demonstrate the adult worm in the ruptured blister. Demonstrate the adult worm in the ruptured blister. And if you demonstrate the adult worm in the ruptured blister, sir, diagnosed, treatment is albendazole, Dracunculus medinensis. Simple, man. So these are the 3 nematodes are causing the tissue infection. Filarial worm, Trichinella spiralis, which tissue is affected? Lymphatic tissue, subcutaneous tissue, muscle tissue, skin tissue. You know the manifestation. Then how will you diagnose? DEC provocation test, peripheral blood smear, microfilarial larva. No sheath, no nuclei, ivermectin, onchocerca. Sheath is there, no nuclei, Ucheriaria. Sheath is there, only 2 nuclei, Brugia. Sheath is there, multiple nuclei, Loa. Right? Batchman test positive, Trichinella spiralis. Spiral larva in muscle tissue biopsy, Trichinella spiralis. Skin blister, ruptured, adult worm is coming out, Dracunculus medinensis. Drug of choice for both, albendazole. Right? Albendazole. Okay, now, sir, a patient with fever and swelling, positive for filarial antigen. What is the next step? Positive for filarial antigen, what is the next step? So, you know, we do DEC provocation test. And after that, we do peripheral blood smear. If positive filarial antigen, sir, positive filarial antigen means microfilaria, right, is present in the blood. Microfilaria is present in the blood. Sir, what if microfilaria present in the blood? Sir, if microfilaria present in the blood, right, no need to do DEC provocation test. Directly go for, right, peripheral blood smear. Peripheral blood smear. Right? So peripheral blood smear is the answer. Because positive filarial antigen is mentioned. If positive filarial antigen is not mentioned, so it says microfilaria is not present in the blood. Microfilaria is not present in the blood, then you have to do DEC provocation test. So that microfilaria will come into blood. Then you have to go for peripheral blood smear. Because in this question, positive filarial antigen mentioned, so directly go for peripheral blood smear. Don't go for DEC provocation test. Right? Then microfilaria with sheath surrounding it. Sir, there is a sheath. There is a sheath means rule out onchocerca, because you know onchocerca there is no sheath. And now we divide based on sheath and no sheath. right? Surrounding it, two big nuclei, sir, two nuclei. Sir, sheath is there and there are two nuclei. Sheath is there and there are two. I mean, Brugia malai. Sheath is there and there are two nuclei. Brugia malai. Right? Very simple. So moving on to the next. A male patient presented with the swelling of the right thigh. Sir, swelling of the right thigh. Peripheral blood smear show ensheathed larva. Ensheathed larva means again sheath is there. Again sheath is there. It is not unsheathed, it is ensheathed. With no nuclei in the tail tip. Sir, no nuclei in the tail tip. Sir, sheath is there, no nuclei. Sheath is there, no nuclei. Now you know Ucheraria Bancroft. It's so easy to answer. Sheath is there, no nuclei. Ucheraria. Sheath is there, two nuclei. Sheath is there, two nuclei. Right? Brugia malai. Simple man answered. Sir, with that parasitology is over. Moving on to the last part, mycology. Moving on to the last part, mycology. With that, today's session is over. Sir, if you talk about mycology, important systemic dimorphic fungal diseases. Important systemic. Sir, important means only important. Right? Systemic means affecting the systems. Affecting the systems. And the most common system affected is respiratory system, then etc, etc, etc. Many more systems are affected, but most common is respiratory system. Dimorphic. Dimorphic fungi means the fungi which is having yeast form and also mold form. Dimorphic means the fungi which are having yeast form and mold form. Okay, important means important, involving the system. Many systems are involved, but most common is respiratory system. Dimorphic means which present in the form of yeast and mold. Fungal diseases. So dimorphic fungi are 6, but important are 2. Important are 2. We are discussing 2 important systemic dimorphic fungal diseases, and those 2 important systemic dimorphic fungal diseases are histoplasmosis and talaromycosis. Histoplasmosis, talaromycosis. Right? And remember, talaromycosis produces red pigment on SDA. So pigment producing fungi are very important. Pigment producing fungi are very important. And remember, red pigment is produced by, one is talaromyces and one more is Trichophyton rubrum. One more is Trichophyton rubrum. And a red pigment producing fungi are very important. And remember, 2 fungi produces red pigment. 2 fungi produces red pigment. Which are the 2 fungi? One is talaromycosis. One more is Trichophyton rubrum. These are the 2 fungi that produces red pigment on SDA. Pigment producing fungi, very, very important. Right now, Trichophyton rubrum, you just ignore because it causes dermatophytosis. We have mentioned because it produces red pigment along with talaromyces. Now concentrate on histoplasmosis and talaromycosis. Right? Histoplasmosis is caused by histoplasma. Talaromyces is caused by Talaromyces marnefi. Both are dimorphic fungi. Both are dimorphic fungi. And what do they cause? I told you they are systemic. They affect mainly respiratory system. So respiratory system is affected. They cause pneumonia. They cause pneumonia. And remember, pneumonia with nodular lesions. Pneumonia with nodular lesions. And also they cause skin nodules. Right? They cause nodules in the lung also, nodules in the skin also. Pneumonia with lung nodules, skin with skin lesions with skin nodules. That is the nodular lesions are important. Lung and also on the skin. Lung, both are dimorphic fungi. Sir, both are dimorphic fungi. Talaromyces produces red pigment on SDA. So this is the red pigment. Right? What has shown here is red pigment. Okay, this is the red pigment. What has shown here is red pigment. Okay, this is also red pigment. Red pigment. Right? Red pigment. And this is the yeast form. This is the yeast form. And sir, this is the mold form. This is the mold form. Mold form. Yeast form and mold form. Yeast form, what do you see? Sir, yeast form, I see oval shaped yeast cells with a septum. Oval shaped yeast cell with a septum. Right? Oval shape with a septum. Oval shape with a septum. Confirm talaromyces. Talaromyces. Right? Here what do you see? Sir, I see a branching conidiophore. I see a branching conidiophore. Branching conidiophore. So these are phaeolites. These are phaeolites. And those lines are conidia. Those lines are conidia. Sir, this is conidia. These are chains of conidia, and these are phagellates, and this is branching conidiophore. This is branching conidiophore. So this is the mold form of Talaromyces marnefi. So red pigment on culture, right? Oval shape yeast with septum in the yeast form, branching conidiophore phagellates with chains of conidia in the mold form. So this is how you identify Talaromyces marnefi. This is how you identify Talaromyces marnefi, which causes talaromycosis. Manifest with nodular lesions in the skin and also in the lung. Right? Histoplasma. Sir, histoplasma, right? This is the yeast form. Histoplasma, sir. This is the yeast form, and this is the mold form. Sir, yeast form may you see macrophage. This is macrophage. This is the nucleus of macrophage, and you see yeast cells. Sir, mold form may you see conidia surrounded by tubercles. Conidia surrounded by tubercles. Okay, conidia surrounded by tubercles. Okay, just a second. I will mention here, right? Intracellular yeast. Right? Yeast within the cell. Intracellular yeast. Conidia with tubercles. So this is how you identify histoplasma. Right? In the yeast form and in the mold form. Right? In the yeast form and in the mold form. Right? So this is about histoplasmosis and talaromycosis. Two important dimorphic fungal diseases affecting the respiratory system and skin: nodular lesions, yeast form of histoplasma, intracellular yeast, and conidia with tubercles. Right? And oval shaped yeast with branching conidiophore phagellates and chains of conidia and red pigment. So this is how you identify. Very, very important. Very important. Histoplasmosis, talaromycosis. Important systemic dimorphic fungal disease. Now if you see the question, right? A HIV patient with low CD4 count presented with bilateral nodular lung lesions. Right? I want to highlight nodular lung lesions. And skin manifestation as shown in the image. So skin manifestation are skin nodules. The nodular lung lesions, nodular skin lesions. Right? CB-NAT is negative. That also I want to highlight. CB-NAT was negative. So CB-NAT was negative. Why particularly examiner has to mention CB-NAT negative? Examiner has to mention CB-NAT negative because very important point you have to see here. So nodular lung lesions are seen in TB and histoplasmosis. So molluscum contagiosum, cryptococcus are ruled out because nodular lung lesions are not seen. It is not just lung lesion, it is nodular lung lesions. Nodular lung lesions are seen in histoplasmosis and tuberculosis. And by giving CB-NAT negative, examiner is telling, right, it is not tuberculosis. The answer is histoplasmosis. By seeing the skin image, don't think it as umbilicated papules because they look like umbilicated papules also. And you go for molluscum contagiosum. No, don't go for molluscum contagiosum because nodular lung lesions are not seen in molluscum contagiosum. Nodular skin lesions are not seen in molluscum contagiosum. Nodular lung lesions are seen only in, right, dimorphic pneumonia. Remember, dimorphic fungal pneumonia and tuberculosis. Remember this word. Nodular lung lesions are seen in dimorphic pneumonia, dimorphic fungal pneumonia and tuberculosis. Dimorphic fungal pneumonia and tuberculosis. Sir, God bless you, sir, for teaching this important session in YouTube. Welcome, man. Thank you. God bless you too. God bless you all. You people just take the good seat in the NEET. That's it. That is our aim. Take the good seat in the. Okay. Remember this nodular lung lesions. I will highlight nodular lung lesions. That is important. Nodular lung lesions. Nodular lung lesions are seen with dimorphic fungal pneumonia. Dimorphic fungal pneumonia and tuberculosis. Right here, tuberculosis is ruled out because question said CB net negative, and dimorphic is histoplasma. Dimorphic is that's why answer is histoplasma. The next question: a HIV patient presented with fever and cough, breathlessness. Sir, breathlessness means diagnosis is pneumonia. Breathing difficulty means diagnosis is pneumonia, right? Fungi showing yeast form at 37, mold form at 25. So yeast form and mold form, so dimorphic fungal pneumonia. Right, as shown in the image. In the image, what do you see? Sir, I see branching conidiophore and a branching conidiophore with phalanx, with chains of conidia. Right, clear cut it says Talaromyces marnefi. Clear cut it says Talaromyces marnefi. Right, Talaromyces marnefi. Right, sir, want the PDF? Okay, I will provide you in the Telegram group. Okay, Talaromyces marnefi. Okay, Talaromyces marnefi. Simple. Fine. Okay, next question, sir. Sir, important. Right, we are about to end our session. End of our session. Important opportunistic fungal diseases. Sir, important opportunistic fungal diseases are 5. Important opportunistic fungal diseases are 5. Candidiasis, cryptococcosis, aspergillosis, mucormycosis, and then finally sir, pneumocystosis. 5 important opportunistic fungal diseases. And remember, candidiasis is having BDG, beta D glucan, invasive marker for invasive candidiasis BDG, and not there for cryptococcosis. Invasive marker is there for candidiasis, not there for cryptococcosis, and it is there for aspergillosis, and it is not there for mucormycosis, and it is there for pneumocystosis. Right, alternate diseases, man. Alternate diseases have invasive markers. Remember this. Alternate diseases have invasive markers. Invasive marker is there for candidiasis, not there for cryptococcosis, there for aspergillosis, not there for mucormycosis, there for pneumocystosis. First remember where the marker is. Alternate diseases. Then remember what is the marker. Marker is BDG. BDG for invasive candidiasis, BDG for invasive aspergillosis, BDG for invasive pneumocystosis. BDG means beta D glucan. Right, beta D glucan. BDG means beta D glucan. BDG means beta D glucan. Okay. Now remember, aspergillosis is having BDG and also galactomannan. There are 2 invasive markers. Markers for invasive. These are invasive markers. Marker for invasive fungal infection. Okay? Easy to remember the markers. Once again I will tell you. First remember where the markers are. Invasive markers are present in there in candidiasis, not there in cryptococcosis, there in aspergillosis, not there in mucormycosis, and there in pneumocystosis. And remember wherever it is there, BDG. But aspergillosis is having BDG and galactomannan. बहुत simple man हो गया. With that, let's start one by one. Candidiasis. Invasive marker is there. Yes. What is that BDG? What does it affect? Sir, Candida affects skin and mucous membrane. Which mucous membrane? Oral mucosa, oral candidiasis, esophageal mucosa, esophageal candidiasis, vaginal mucosa, vaginal candidiasis. है ना, vaginal mucosa, vaginal candidiasis, skin and mucous membrane, site is affected. Okay, fine, sir. Then what are we seeing here? That you are seeing GTT. What you are seeing? GTT. What is GTT? Germ tube test. What are you seeing here is chrome agar culture. Germ tube test and chrome agar culture. So germ tube test is positive. Germ tube test is positive. Candida albicans species. Candida albicans species. Remember, germ tube test can identify only albicans species. That is important. Chrome agar can identify all species. Chrome agar can identify all species. That is important. How will you identify the species of Candida? Germ tube test identify Candida albicans species. That is the most common species. It is the most common species. Chrome agar culture will identify all the species. Sir, what is germ tube test? See, you see the formation of germ tube. See, this is the germ tube. Germ tube is formed, say albicans. Dublinensis also produces germ tube, I know. Forget it off. Don't complicate things. Keep it simple. Germ tube is produced. So this is Candida and that is germ tube. Germ tube is there, Candida albicans. Simple. Sir, chrome agar. Chrome agar mein what happens? Different Candida produces different color colonies. Different Candida species produces different color colonies. है ना, ये ग्रीन कलर है ना, ये ग्रीन कलर दैट इज एल्बिकन्स, ये पर्पल कलर ट्रॉपिकैलिस, पिंक कलर क्रूजी, cream color glaberita. Different species, different colors. But you have to remember, germ tube test you can identify only albican species. Albicans produces germ tube, and chrome agar you can identify all the species. Once you have identified Candida, what is the treatment? The treatment, observe here, very important. Topical treatment for candidiasis, oral treatment for candidiasis, and if the resistant Candida is there, what is the treatment? So topical treatment. Topical treatment, if you know, Candida, just now I told, Candida affects skin and mucous membrane. Candida affects skin and mucous membrane. Sir, skin के लिए we use clotrimazole or nystatin. Skin के लिए we have to use clotrimazole or nystatin. Mucous membrane के लिए only clotrimazole. Mucous membrane के. So local application is clotrimazole for skin and mucous membrane. Clotrimazole for skin and mucous membrane. Local application. Nystatin can be used. Nystatin can be used only for the skin, not for mucous membrane. Orally we have to take fluconazole. If it is resistant, then you have to take caspofungin. This is the treatment of Candida. Topical में skin के लिए and mucous membrane के लिए. Then oral, then resistant Candida. What is the treatment? Very important. Right? Very important. Very important. Right. Sir, we are done with the candidiasis. Cryptococcosis. Sir, cryptococcosis is no marker, no invasive marker. Most common site is lung. That is important. Most common. See, I have written greater than symbol. Most common site is lung causing pneumonia. It can cause meningitis, no doubt in that. But most common site is lung causing pneumonia. How will you confirm cryptococcus? Sir, negative stain. है ना? Negative stain. And bird seed agar culture. Negative stain and bird seed agar culture. Sir, negative stain mein what do you see? Capsule. What are we seeing here? Capsule. Chrome agar culture mein what do you see? Brown colonies. Brown colonies. And what are these? Why the colonies are brown? Sir, colonies are brown because of melanin pigment. Because of melanin pigment produced by cryptococcus. Right. Sir, how will you confirm means? Remember this point. Cryptococcus is having capsule and cryptococcus produces melanin pigment, a brown color pigment. And how will you demonstrate the capsule? Negative staining to demonstrate the capsule. How will you demonstrate the melanin pigment? Bird seed agar culture will demonstrate the melanin pigment. That's how you confirm cryptococcus. Okay. Cryptococcus contain capsule and it can produce melanin pigment. How will you demonstrate capsule? Negative staining. How will you demonstrate the melanin pigment? Brown colonies on bird seed agar. That's how you confirm cryptococcus. Cryptococcus is confirmed. What is the treatment? Treatment is liposomal amphotericin B plus fluconazole. In severe cases, we have to add flucytosine. So with that we have completed cryptococcosis, candidiasis and cryptococcosis. Once again, I will tell you what to remember. Candidiasis, invasive marker is seen. Invasive marker is BDG. Cryptococcosis, no invasive marker. Candida affects skin and mucous membrane. Which mucous membrane? Oral mucosa, esophageal mucosa, vaginal mucosa. So oral candidiasis, esophageal candidiasis, vaginal candidiasis. Cryptococcus, most common site is lung, causes pneumonia. Second most common is meninges, causing meningitis. The tests are important. The pictures are very important. germ tube test to identify albicans species, chrome agar culture to identify all the species of Candida, negative staining to confirm the capsule of Cryptococcus, bird seed agar culture to demonstrate melanin pigment in the form of brown color colonies on blood agar to confirm Cryptococcus. And the treatment. Topical treatment for skin and mucous membrane, clotrimazole. Nystatin can be used only for skin, not for mucous membrane. Orally, we have to take fluconazole. If Candida is resistant, we have to go for caspofungin. Treatment for cryptococcus is liposomal amphotericin B plus fluconazole. In severe cases, we need to add flucytosine. Are very important, man. Candidiasis and cryptococcosis. So, moving on to the aspergillosis. Right. Sir, invasive marker is seen. Yes. What is the invasive marker? Two invasive markers, BDG and galactomannan. What does it cause? It causes pneumonia, sinusitis, ABPA and aspergilloma. ABPA means allergic bronchopulmonary aspergillosis. Allergic bronchopulmonary aspergillosis. Right? ABPA. Now, what do you see? Sir, I see this is very important. I see hyphae with two branches, hyphae with two branches, hyphae with two branches, hyphae with two branches. When every hyphae gives two branches, this is what we call it as dichotomous branching. Very important. Dichotomous branching. Every branch gives only two branches. Every hyphae gives two branches. And if you see the angle, right? 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 If you see the angle, the angle is acute angle. Sir, acute angle and dichotomous branching. Acute angle and dichotomous branching. Aspergillus. Once you say aspergillus, how do you confirm Niger, flavus and fumigatus? So this is aspergillus niger. This is aspergillus flavus. This is aspergillus fumigatus. Right? This is how you identify the species. Sir, how will you identify the species? For that, I want to tell this is vesicle. Right? I want to tell this is vesicle. Right? What is this? Vesicle. See how much of the vesicle is surrounded by conidia. See and tell. Sir, complete vesicle is surrounded by. Sir, complete vesicle is surrounded by conidia. So Niger. Here you see how much of the vesicle is surrounded by conidia. Not complete. Not complete. 2/3 of the vesicle. If 2/3 of the vesicle is surrounded by conidia flavus, here you see how much of the vesicle. Sir, 1/3 of the vesicle. 1/3 of the vesicle is surrounded by conidia. So it is fumigatus. This is how you identify. And the most common species is fumigatus. Right? Sir, now acute angle and dichotomous branching confirmed aspergillus. Then how to identify species? See how much of the vesicle. Vesicle means the round orange color structure. Okay, this is vesicle. Round orange color structure is vesicle. How much of the vesicle is surrounded by conidia? Complete vesicle to Niger. 2/3 of the vesicle to flavus. 1/3 of the vesicle to fumigatus. Identified aspergillus. So treatment, drug of choice is oriconazole. Aspergillus is done. Two invasive markers, BDG and galactomannan. Invasive marker is seen in aspergillosis, so not seen in mucormycosis, and a no marker. I told you alternate. Mucormycosis is also known as zygomycosis. The most common site is rhinocerebral, nose and brain. Second most common site is lung, pneumonia. And what is more important here is to remember, mucormycosis is most commonly seen in diabetic ketoacidosis patient, iron therapy patient, and post-COVID. And it was popularly known as black fungus, post-COVID. These are the three risk factors. Risk factors are important to remember. Okay, risk factors are important to remember. Risk factors are important to remember. Okay, Okay, fine, sir. Then what do you see? Sir, I see hyphae. I see hyphae. Right? I see hyphae. Sir, broad hyphae. Right? I see hyphae. How the hyphae are? Hyphae are broad. Hyphae are broad. Broad hyphae. With see right angle branching. Right? Right angle branching. If you see the angle, right angle. Right? Right angle branching. Right angle branching. Sir, broad hyphae with right angle branching. Broad hyphae with right angle. Sir, broad hyphae. Broad hyphae, ribbon like hyphae. Broad hyphae, ribbon like hyphae. Right? Up, right angle branching. Right angle. Or obtuse angle. Right angle or obtuse angle branching. Right? Broad, ribbon like hyphae. Right angle or obtuse angle branching. Right? You can see Mucormycetes group of fungi. Mucormycetes group of fungi. But which Mucormycetes group of fungi? That you will come to know when you see root-like structures. When you see root-like structures. And remember, this is the point which is known as nodal point. This is nodal point. This is nodal point. This is nodal point. This red color point is known as nodal point. This red color point is known as nodal point. Right? And these root-like structures are known as rhizoids. These root-like structures are known as rhizoids. So rhizoids are root-like structures. You have to see where they are arising from. You have to see where they are. So this is class like Ultra 1 short course. Thank you guys. Best microbiology faculty. Thank you. Sir, from where the rhizoids are arising, you have to see. Right? Nodal rhizoids. Right? Nodal rhizoids. Nodal rhizoids. Rhizoids are arising from nodal point to rhizopus. Internodal rhizoids. Internodal rhizoids. So rhizoids are arising from internodal point between the nodes. Absidia. So no rhizoids. No rhizoids. So mucor. No rhizoids. Sir, mucor. Okay, thank you. No rhizoids or mucor. See here, rhizopus, absidia, mucor. That's how you identify. So first you identify these are Mucormycetes group of fungi. How will you identify these are Mucormycetes group of fungi? Broad ribbon-like obtuse angle, right angle branching hyphae. Mucormycetes. Nodal rhizoids, rhizopus, internodal rhizoids, absidia, no rhizoids, mucor. What is nodal point? I told you that is the nodal point. Rhizoids means root-like structure. Sir, what is the treatment? Sir, first, before treatment, first you need to know, right? Before treatment, first you need to know that guideline says first you have to do MRI brain. Guideline says first you have to do MRI brain, and then you have to diagnose. Then you have to diagnose, right? That is, what is that? Whatever we have done the diagnosis, and then you have to go for surgery. Then you have to go for surgery, and then the treatment liposomal amphotericin B plus posaconazole, right? So first MRI brain and then sample diagnosis. Then sample diagnosis. I will write down here, otherwise you will get confused. Right? What we have done is sample diagnosis. And steps are important. This is the first step, this is the second step, this is the third step, and this is the fourth step to be done. The 2 steps in diagnosis, 2 steps in treatment. The 2 steps in diagnosis are MRI brain first, sample diagnosis. Next, in the sample diagnosis, take the sample, see broad ribbon-like aseptate hyphae, right? Acute obtuse angle and right angle. So Mucormycetes, nodal rhizoids, absidia, no rhizoids. Nodal rhizoids, rhizoids, internodal rhizoids, absidia, no rhizoids, mucor. Then do the surgery, then start a liposomal amphotericin B with posaconazole, right? Posaconazole. Right, great for your teaching, sir. Thank you. Okay, thank you very much, guys. We'll finish it off. Aspergillosis and mucormycosis. The last ones are pneumocystosis. Last one means what? You know, we are discussing important opportunistic fungal diseases. I told BDG is there in candidiasis, not there in cryptococcosis. BDG and galactomannan is there in aspergillosis, not there in mucormycosis. BDG is there in pneumocystosis. So pneumocystosis is caused by pneumocystis jirovecii. It causes pneumonia. It causes pneumonia. Sir, microscopy. Microscopy में sir you have to do GMS stain. Gomori methanamine silver stain. GMS means Gomori methanamine silver stain. Sir, how will I come to know this is Gomori methanamine silver stain? Sir, Gomori methanamine silver stain gives black color to fungi, green color to background. If you see black color fungi, green color background, it is Gomori methanamine silver stain. And what are you seeing here? Sir, I am seeing crescent shape, crescent shape, black color cyst. I will highlight here one thing. What is that? Cyst. Sir, why you will highlight the cyst? The only fungus which appear in the form of cyst, Pneumocystis jirovecii. The only fungus that appear in the form of cyst, Pneumocystis jirovecii. And it is appearing black color because it is GMS stain. GMS stain gives black color to the cyst, green color to the background. Black color to the cyst, green color to the background. चलो निमोनिक आ गया यार यहाँ पे, किसी ने निमोनिक दे दिया CAP कैप, वो तो मोस्ट कॉमन यूज निमोनिक है, लेकिन you have seen my class from beginning till now I have not used mnemonics. I avoid mnemonics. चाहिए तो मैं better mnemonics दे सकता हूँ. I avoid mnemonics. My class is usually without mnemonics. Still students can remember everything. That is tricks and techniques, right? Because mnemonics say how much you can remember, man. How much you can remember? You only think. एक सब्जेक्ट में 10 निमोनिक भी बना लोगे, 1 सब्जेक्ट में 10 निमोनिक भी बना लोगे, 19 सब्जेक्ट्स में 190 निमोनिक्स. Can you remember? Right? 190 mnemonics, can you remember? No. That too if you make just 10 in one subject. यार आप तो 100 निमोनिक बनाते हो हर एक सब्जेक्ट में. Right? Be practical, man. Right? Find out the alternate methods to remember. है ना? सर आपको ही पता है क्या मैं 100-200 निमोनिक याद रख सकता हूँ? नहीं. तो बनाते क्यों हो? तो सर करना क्या है? सोचो यार, दिमाग दिया है खुदा ने. Right? That is what is tested in the exam also. Examiner also says use your brain in the exam. AM also says use your brain to remember. Don't ऐसा नहीं कि उनके mnemonics नहीं बनाए. I'm not telling you not to make mnemonics. Make mnemonics. But for everything there is a limit. You know, too much of too good is also too bad. Too much of too good is also too bad. Right? Till a limit, making mnemonics is accepted. Out of the limit, it is going to harm you. It is not going to benefit you. Right? I'm not telling not to make. For everything there is a limit. When you cross the limit, when you know this much mnemonics I can't remember, so why you make so much mnemonics? Right? You have to use mnemonics only whenever it is much needed. Otherwise you should not use, because more mnemonics you can't remember. And remember the sentence, too much of too good become too bad. अच्छा भी बहुत ज्यादा हो जाएगा तो बुरा बन जाता है. Right? बुरा बन गया तो क्या होता है? फायदा तो छोड़ो यार, नुकसान देता है. फायदा नहीं देता, उसको छोड़ दो, नुकसान देगा ना. Right? Benefit you're not going to get, but it is going to harm you. If too much of too good, if you do, if it is not giving benefit, it's okay, but it is going to harm you. Students, man, everything you know, how much to read, how much content to cover. One problem with the students is they cover more content. Right? Again, too much of content covering is too bad. How much to cover you should know. Too much of mnemonics too bad. How much to make is you know. Right? What to read first, what to read next, you know. Rare things should not be read in the first. That is what is planning. Use your brain, and that is what examiner says in the exam. You know, आप लोग बोलते हैं सर सब पढ़ के गया था, फिर वो एग्जाम में मुझे पता नहीं क्या हो गया सर. यार एग्जामिनर ना पढ़ के आने के लिए नहीं बोला, पढ़ के आके दिमाग यूज करने के लिए बोला. So you have to use your brain. You have to practice using your brain. When something it is not possible, then you should not do it. Go with the alternate methods by which it is possible. Okay, anyways, so with that crust ping pong ball appear, right? किसी ने देखा crust black color cyst which are present crescent shape, किसी ने इसको imagine किया ping pong balls, तो he called as crust ping pong ball appearance. Both are same. Crust ping pong ball appearance. Crust ping. सर मेरा एक सेंटेंस याद रख लो यार, इस what जो भी मैं अभी डिस्कशन किया उसके लिए एक टेक होम मैसेज याद रख लो. Too much of too good is too bad. Too much of too good is too bad. Covering too much of content is also too bad. Don't think toppers cover everything. Toppers will not cover everything. They know what to cover, what not to cover. Too much of too good is too much of covering content, too much of mnemonics. Anything, man, which you feel good. If it crosses the limit, it becomes bad. When it becomes bad, not only you're not getting the benefit, instead it is going to harm you. That should not happen. You are mature enough, you know what to do, how much to do. You have to do that much. So with that, sir, pneumocystis cerevisiae causes pneumonia and the marker is BDG. Right, on microscopy, on GMS staining, you see crust, crescent shaped black color cyst, crust ping pong ball appearance. And remember, this is the non-cultivable fungus. The only non-cultivable fungus, very important. The only sir, microscopy, GMS staining picture, very, very important. Causes pneumonia. Done. Drug of choice is cotrimazole. Drug of choice is cotrimazole, not clotrimazole, cotrimazole, right? Trimethoprim plus sulfamethoxazole. Trimethoprim plus sulfamethoxazole. Cotrimazole is the drug of choice. So pneumocystis cerevisiae is done. With that, five important opportunistic fungal infections are done. Candidiasis and cryptococcosis, aspergillosis and mucormycosis and pneumocystosis. Never forget. फिर से बोल रहा हूँ, याद रख लो. Candidiasis and cryptococcosis, aspergillosis and mucormycosis and pneumocystosis. Where do you see invasive marker? Sir, invasive marker is seen in candidiasis, not seen in cryptococcosis, seen in aspergillosis, not seen in mucormycosis, seen in pneumocystosis. Better to remember than cap. You never forget. Better to remember than a mnemonic cap. You will never forget. And which is the marker? BDG. And aspergillosis is having two markers, BDG and galactomannan. And treatment is very, very important. Yeah, treatment. Treatment is very, very, very important. Pictures, images are also very, very, very important. Images, treatment of candidiasis and cryptococcosis, treatment of aspergillosis, mucormycosis, and some pneumocystosis. The way I have explained these, this is very, very important, right? Go and read this. You will come to know how easy it is. Okay, now see the questions, man. We are done with the session. See the questions, man. A female patient presented with curdy white discharge. What discharge, man? Curdy white discharge. They have to mention vaginal discharge, Curdy white vaginal discharge, man. Vaginitis. Curdy white. I will highlight curdy white. Curdy white, so I will say fungal vaginitis. Fungal vaginitis, vaginal mucosa. We have already discussed, caused by candida. Microscopy showed budding E cell with pseudohyphae. Sir, budding E cell and pseudohyphae are again candida. Only candida shows pseudohyphae. Which medium is used to differentiate? Okay, I will highlight which medium is used to differentiate the species. Don't say SDA. Don't say Burt-Sitagar. Don't say PDA. You know chromagar. Right, chromagar. है ना? Differentiate the species. Candida का species you can differentiate based on chromagar. All the species can be differentiated based on chromagar. Sir, a patient with history of asthma on inhalational steroids. So that means immunocompromised condition. Manifested with white patches in the oral cavity. Sir, white patches in the oral cavity, man. Candida. Sir, diagnosis is oral candidiasis. What is the treatment? Oral candidiasis. Clotrimazole, flucytosine, terbinafine, griseofulvin. What is the treatment? सर अजोल, सर द ड्रग ऑफ चॉइस, है ना. देखो यार कैंडिडियासिस का ट्रीटमेंट देखो, एक बार फिर से दिखाऊंगा यार, ट्रीटमेंट देख लो. राइट, कैंडिडियासिस का ट्रीटमेंट वेरी इंपॉर्टेंट है यार, इसलिए फिर से दिखा रहा हूँ. टॉपिकली स्किन एंड म्यूकस मेम्ब्रेन, क्लॉट्रीमाजोल. Nystatin can be used only for the skin, not for the mucous membrane. Orally fluconazole, resistant caspofungin. If you see these drugs, which is the drug which is present here? So the drug which is present is clotrimazole, and clotrimazole is used for the topical application, local application, clotrimazole. Right, clotrimazole. Nystatin nahi yaar, nystatin nahi, don't say nystatin please. I told nystatin is used only on the skin, not on the mucous membrane. Don't say nystatin. Again, nystatin only for the skin, not for mucous membrane. This is mucous membrane. Nystatin nahi kaise. Nystatin is only for the skin. Don't get confused. That's why I have specifically have specified So nystatin is only for the skin, not for mucous membrane. Clotrimazole can be used for both skin and mucous membrane. Vaginal candidates, don't say nystatin. You should not apply. Then gone. Then gone. You should not apply. Sir, clotrimazole. The next, sir, a truck driver manifested with pneumonia. Sample histopathology showed the dichotomous branching. Man, kitna simple question hai, dichotomous branching. The dichotomous branching is seen with aspergillus, hai na? Every hyphae gives only 2 branches. See, every hyphae gives only 2 branches. Har ek branch, every hyphae, and angle is acute angle. Sir, acute angle and dichotomous branching, aspergillus. So next question, a diabetic patient, right? A diabetic patient recovered from COVID-19. You know, this is the mucormycosis, man. Diabetic patient, facial pain and teeth pain. Why facial pain and teeth pain? Man, rhinocerebral mucormycosis, because nose is involved. Patient will get facial pain and teeth pain. What is the next best investigation? You know, first is MRI head imaging. MRI head imaging. Yeah, dekho yaar, I have mentioned, and I have mentioned the number also for the steps, right? I have mentioned the numbers also for the steps. If you remember, if you see here, first step is MRI brain, second step is sample diagnosis, third step is surgery, fourth is liposomal lymphocyte. Sir, first is MRI brain, that is important. See here, that's why first is MRI brain. Don't say nasal swab for mucor. Sir, first step. This is second step, sample diagnosis, right? This is first step, this is second step. First step is MRI head imaging. Sir, a HIV patient with pneumonia, immunocompromised patient with pneumonia, right? Ball KOH wet mount. Okay, negative for ball KOH wet mount. But see here, Gomori methanamine silver stain shows crescent shaped black color cyst, and the fungus was non-cultivable. कितना अच्छे से पूछा यार क्वेश्चन, पूरा बता दिया, राइट? कितना अच्छे से पूछ रहा है, आंसर क्या है? ये तो बच्चों जैसा क्वेश्चन हो गया, क्योंकि अभी हमको कॉन्सेप्ट्स पता है, की पॉइंट्स पता है, टॉपिक पता है, PYQ टॉपिक पता है, right? Pneumocystosis. Sir, moving on to the next question. Okay. Last, I thought it is over. Okay, last guys, thank you आ गया, एक चीज बच चुका है, बस हो गया, देखो, थैंक यू आ गया, सॉरी फॉर द डिले. ओके, बट इंपॉर्टेंट टॉपिक सारे कवर करना था ना. अगर मैं थोड़े टॉपिक कम करता तो जल्दी खत्म हो जाता, थोड़े टॉपिक कम कर लेता ना, जल्दी कवर हो जाता. बट इंपॉर्टेंट टॉपिक्स पूरे ना सारे इंपॉर्टेंट है, राइट? PYQ टॉपिक्स एक जगह पे आपको मिल रहे हैं, रीसेंट पूरे 3 से 5 साल के, नॉट पूरे, इंपॉर्टेंट टॉपिक्स इन 3 to, not all important PYQ topics of 3 to 5 years, not all, right? But इतना अच्छा कहीं भी नहीं मिलेगा. Another 10 minutes will wind it up. So now we are talking about here, the headline is subcutaneous fungal diseases, right? Subcutaneous fungal diseases. The topic is subcutaneous fungal diseases. Respect sir from Bangalore. Respect ಕೊಟ್ಟಿದ್ದಕ್ಕೆ ಥ್ಯಾಂಕ್ಸ್ ಅಪ್ಪ. ನೀವು ಚೆನ್ನಾಗಿ ಓದಿ ಚೆನ್ನಾಗಿ ಮಾಡಿದ್ರೆ ನಮ್ಗೆ ಇನ್ನೂ ಒಳ್ಳೆ ರೆಸ್ಪೆಕ್ಟ್ ಸಿಗುತ್ತೆ. ಇದೆಲ್ಲ ಮಾಡ್ತಿರೋದು ನೀವು ಸೀಟ್ ತಗೊಳ್ಳಿ ಅಂತ, ನೀವು ಸೀಟ್ ಬೇಗ ತಗೋಬಿಡಿ ಅಷ್ಟೇ, ನಮ್ಮ ಆಶೀರ್ವಾದ ನಿಮ್ಮ ಜೊತೆ ಇದೆ. Sir, subcutaneous fungal diseases. The fungal disease affecting the subcutaneous tissue. Sir, how many diseases affect subcutaneous tissue? Right, one is mycetoma, which is also known as Madura foot. One more is sporotrichosis, which is also known as rose gardener's disease, and two more diseases, chromoblastomycosis and pheohypomycosis. Sir, there are 4 diseases. Okay, sir, there are 4 diseases that affect subcutaneous tissue. Sir, all of them they manifest with subcutaneous nodules. Remember, subcutaneous fungal diseases are 4. First, tell me the 4 subcutaneous fungal diseases. Mycetoma and sporotrichosis, chromoblastomycosis and pheohypomycosis. Easy to remember. Remember 2 plus 2. Mycetoma and sporotrichosis, chromoblastomycosis and pheohypomycosis. These are the 4 subcutaneous fungal diseases. Okay, all of them they manifest with subcutaneous nodules. All of them, they manifest with subcutaneous nodules. Along with the subcutaneous nodules, if you see discharging granules, along with the subcutaneous nodules, if you see discharging granules, mycetoma. Along with the subcutaneous nodules, if you see subcutaneous nodules along the lymphatics, if you see subcutaneous nodules along the lymphatics, sir, it is sporotrichosis. If you see subcutaneous nodules with verrucous lesions, if you see subcutaneous nodules with verrucous lesions, sir, chromoblastomycosis and phaeohypomycosis. Okay, what are verrucous lesions? So these are verrucous lesions. What are verrucous lesions? The lesions which look like warts or cauliflower. Right, the lesions which look like warts or cauliflower. Wart like or cauliflower like lesions. Wart like or cauliflower like lesions are verrucous lesions. Verrucous lesions. Okay, seen in both chromoblastomycosis and phaeohypomycosis. See, once again I'm telling you, there are 4 fungal diseases that affect the subcutaneous tissue, and all of them, they manifest with subcutaneous nodules. Along with the subcutaneous nodules, if you see discharging granules, mycetoma. If you see subcutaneous nodules in a line along the lymphatics, sporotrichosis. Along with the subcutaneous nodules, if you see verrucous lesions, chromoblastomycosis and phaeohypomycosis. Right, clinically how to identify. ठीक है, अभी lab diagnostically how to identify. So this is the foot में you see subcutaneous nodules, and in the subcutaneous nodules, guys, you are seeing discharging granule. Subcutaneous nodules, you see discharging granules, right? Discharging granules. Okay, and remember, mycetoma is a disease that is caused by fungi and also bacteria. Fungal mycetoma and bacterial mycetoma. Sir, fungal mycetoma is known as eumycetoma, and bacterial mycetoma is known as actinomycetoma. We have eumycetoma, actinomycetoma, and mycetoma is known as Madura foot because the lesions are seen only on the foot. First case was seen in Madurai, a place in Tamil Nadu, right? And which fungus, right? Which fungus? Okay, which color to use? Okay, sir, which fungus causes most common fungus causing eumycetoma? Madurella mycetomatis is the most common fungus causing eumycetoma and produces black color granules. Yeah, this is important. Produces black color granules. And which bacteria causes actinomycetoma? Nocardia, which is most common in the world, and Actinomadura, which is most common in India. They cause actinomycetoma and they produce whitish yellow color granules. Color of the granules is very important. I will put star mark for the color of the granules. Right, organism you have to tell with color of the granules. Sir, eumycetoma is caused by fungi, Madurella mycetomatis, black color granules. Actinomycetoma caused by Nocardia, which is most common in the world. Actinomadura, which is most common in India, and manifest with whitish color granules. So done with the mycetoma, what you have to remember is color of the granules. Color of the granules. Okay, then sporotrichosis, which is also known as rose gardener's disease, most commonly seen in sub-Himalayan part of India. You see the subcutaneous nodules along the lymphatics caused by a dimorphic fungus, Sporotrichshenki. Caused by a dimorphic fungus, Sporotrichshenki. And you know, dimorphic fungus means it is present in the yeast form and it is present in the mold form. And so this is the yeast form. This is the yeast form. So yeast form may you see yeast cell surrounded by eosinophils. Yeast cell surrounded by eosinophils. That is what you see here. Yeast cell surrounded by eosinophils. Sir, somebody imagine it as star. Somebody imagine it as star and called it as asteroid body. Called it as asteroid body. Asteroid body. Right now, if you see here, sir, I see hyphae along with flowers. Flowers. What is these flowers? These are conidia. Conidia. Sir, conidia arranged. Conidia arranged. Arranged. Like a flower. Conidia arranged like a flower. Like a flower. Along the hyphae. Along the hyphae. If the conidia are arranged like a flower along the hyphae, so this is the yeast form, this is the mold form of Sporotrichshenki. It is a dimorphic fungus. It is the yeast form and it is the mold form of dimorphic fungus. right? So this is what is sporotrichosis. I always tell students, remember sporotrichosis is also known as rose gardener's disease, right? And conidia are also arranged like a flowers. Conidia are also arranged like flowers. And also yeast form, asteroid body, right? And also yeast form, asteroid body. Asteroid body look like a star. Asteroid body means star-like body. That is also look like a flower, no? Because star is a flower. Sun is a star, sunflower. Star looks like a flower. So wherever you see flower-like arrangement, rose gardener's disease, flower, asteroid body, star-like body, flower-like body, star-like, flower-like arrangement of conidia. Sir, flower-like arrangement of conidia. Flower or star-looking body, asteroid body, and rose gardeners is seen in the people who work in the rose gardeners. Wherever you see rose, flower, sporotrichosis. Right, sporotrichosis. So then lastly, sir, chromoblastomycosis and phaeohypomycosis. Chromoblastomycosis and phaeohypomycosis caused by the fungi, right? Caused by the fungi that belongs to demataceous group or phaeoid group. Sir, what do you mean by demataceous group or phaeoid group? Sir, all the fungi that produces brown to black pigment on SDA be grouped under demataceous group. Demataceous means darkly pigmented. Demataceous means darkly pigmented. They produce dark pigment like brown and black pigment on SDA. Okay, there are many fungi, right? There are many fungi. Few of them they produce medullary bodies, which are known as sclerotic bodies. Few of them they do not produce medullary bodies. Sir, few of them they produce medullary bodies or sclerotic bodies. Few of them they do not produce. Demataceous fungi, darkly pigmented fungi. Sir, few of them which produce medullary bodies, they are the medullary bodies. What are medullary bodies? Brown color, round shape, double walled bodies. Some person saw this and imagined it as copper coins. Imagine it as copper coins, and that's why that person called it as copper penny appearance. Sir, appearance is copper penny appearance. They look like copper coins, but what are those? Sir, look like copper coins, copper penny appearance, but what are those? Sir, those are those are medullary bodies or sclerotic bodies. Okay, those are medullary bodies or sclerotic bodies. Acha yaar, we are about to end. Those are medullary bodies or sclerotic bodies. Okay, right? Those are medullary bodies or sclerotic bodies. Produced by which fungi? Sir, produced by demataceous fungi. Sir, few demataceous fungi, they produce as medullary bodies or sclerotic bodies. They look like copper coins, and these are the ones which causes chromoblastomycosis. And few of the demataceous fungi, they do not produce medullary bodies, and these are the ones which causes a disease, phaeohypomycosis. And whether it is chromoblastomycosis or phaeohypomycosis, both of them they manifest with verrucous lesions, and verrucous lesions are wart-like or cauliflower-like lesions. So both of them clinically they manifest same, and organisms are belong to demataceous fungi. But how will you differentiate? Medullary bodies are there or not? Medullary bodies are there, chromoblastomycosis. Medullary bodies are not there, phaeohypomycosis. Don't forget this. With that we have completed last part of our discussion, right? What is that? Subcutaneous fungal diseases. 4 subcutaneous fungal diseases: mycetoma and sporotrichosis, chromoblastomycosis and phaeohypomycosis. If we see 2 to 3 questions, we are done, right, related to this. Okay, see the questions, man. Okay, a 50-year-old manifested with sinuses and discharging granules. See, when you see discharging granules, diagnose it as mycetoma. Mycetoma. That too on the foot, right? That too on the discharging granules on the foot, man, mycetoma. The granules were crushed and examined by histopathological examination as shown in the following image. Sir, what is this you are seeing? Sir, I am seeing a crust granule. What is this? Sir, this is a crust granule. Crust granule. When you crush the granule, granule contains organisms. Organism will come out from the periphery. When you crush the granule, Organisms will come out from the periphery. Somebody imagine it as sun rays, and this person called it as sun ray appearance of crust granule. Sun ray appearance of crust granule. Even if you don't know the image, you can answer the question, because if you know mycetoma, you know mycetoma is caused by bacteria and also fungus. So in the question, if you observe, what they ask is true. What is true? And you know the true is it is caused by bacteria and also fungus. Spread by hematogenous route. It does not involve deep tissue, sparing palms and toes. These are all things we don't know. We don't know. But still we know it is caused both. But that is the true statement. And obviously remaining all are false. It is a subcutaneous mycosis, right? Transmitted by thorn prick injuries or direct contact, not by hematogenous route. It does not involve deep tissue. It involves deep tissue. It involves deep tissue. Sparing palm. It can involve palms and soles also. All are false. Easy question, man. Even if you don't know other options, you know, with the history, you can say it is mycetoma. And when you say mycetoma, you know it is caused by both bacteria and fungi. Sir, a woodcutter got injured while cutting the wood in the forest. Sample showed sclerotic bodies, copper penny appearance. Man, so simple question, man. Copper penny appearance. Sclerotic bodies are seen in chromoblastomycosis, not seen in phaeohypomycosis. Guys, congratulations. हो गया यार. The 10:30 से 11:30, sorry, when we started 8:30, no, 9:30, 10:30, 11:30, 12, 3.5 hours. Sir, I have taken 3.5 hours, right? I know I could have covered in the less time also, but I should have reduced the topics. But what I felt is 3.5 hours is a good time, right? I should not leave any important topic, because students, when they are coming, I should not waste their time. Students' time is very precious. Now I know how much less time you have for NEET exam. I know in how much tension you are with. And with that, I thought, if I, instead of taking 2.5 hours, if I increase 1 hour, not too much also, not too much of too good becomes too bad. So 2.5 hours, 2.5 hours ka session was the planned. Actually, planned session was 2.5 hours, and I took 3.5 hours only because I didn't want to miss few very, very important topics. I didn't feel like to miss, man. Because I can understand in what situation you are and how, in what situation you're going through, right? With that, if you get these topics in one place, I know how it will be beneficial for you, right? Because it will be beneficial for you. That's why, guys, I'm going to share you the PDF also in the Telegram group, because we are here to help you. I know at this moment I can't tell you to write. In the class I have told you I'm against PDF. I don't give PDF, right? But this is not the situation, no. Right? For everything there is situation. Now I want students to write down the notes. That's why even I write down the notes, and every faculty will write down the notes, because everybody wants you to write down the notes. But this is the situation where I know we went fast, we can't write down the notes. Now I can't say I can't provide PDF. I will provide PDF in the Telegram group. Join the Telegram group. Okay, join the Telegram group. And second is, if possible, I will share the Telegram group link also, those who are not with Bhatia. And yes, man, you should be very thankful for Bhatia, man, DBMCI, eGurukul, because man, last year they come up with one shot revision, and this year they come up with the important topics from the previous year papers of NEET, recent 3 to 5 years. Such a good and wonderful sessions. These are wonderful sessions. These are going to be, right? And you should be really thankful to DBMCI Bhatia for conducting these sessions, that too in YouTube, that too live. Right, according to me, these sessions will be there till the NEET exam, right? Most beneficial sessions according to me. If you feel, please comment, man, how the sessions were. See, any doubts related to any question, any topic, please comment in the comment box after the live session, and please comment how the class was and what different you want, how we have to improve, otherwise how really the class was, right? How beneficial it is, right? And really you should be thankful to DBMCA for this. And after me, all faculties are going to come, and DBMC is having best faculty team, whether you agree or not, right? Everybody's opinion is different. I know you may agree, you may not agree, few of you, but I just put my opinion in front of you. Sir, we have very good faculty team. We are coming up with these sessions and hope it will be beneficial for you. Without wasting much time, what I suggest is, attend the session, go and revise, attend the session, go and revise, attend the session, go and revise. This is going to help you for revision. All the important PYQ topics are covered. All the important PYQ topics are covered, right? So that's why attend the session. and go and revise the important topics. Okay, attend the session, go and revise the important topics. Yeah, I have shared you the Telegram group link in the comment box. Right. Sir, if I think you can search Dr. Blueprint. Right, Dr. Blueprint in Telegram. Right, in Telegram. And a Dr. Blueprint. Or Dr. Naseer. Dr. Naseer in the Telegram. Those who want to join for the Telegram group link. Right, I have shared the Telegram group link also. Once again, I'm going to share you. So with that, what I want to say is, guys, prepare well, prepare smart. Right, at the end, I just want to say, prepare well, prepare smart. Okay, prepare well, prepare smart. Remember, too much of too good also becomes too bad. Don't do those mistakes. Now, this last 1 month you have, what you want to do in this 1 month? So if you're not a good seat in INSET, if you're, the situation is very bad, the rank is very bad, then concentrate on the important topics in each and every subject. Don't do much about all other things. Do only PYQs, do only PYQs, do the PYQ topics, do the PYQs, do PYQ topics, PYQs, PYQ topics, but you should be thorough. But you should be thorough. Remember this, you should be thorough. You should be thorough. Right? Thorough means what? Sir, you ask anything from the PYQ topics. Sir, kitne saal, 3 years or 5 years? This is also a question. 3 years or 5 years? Yaar, pehle 3 saal ka kar lo yaar. Once you are thorough with the 3 years, then add another 1 or 2 years. Sir, INSET ka PYQs also we have to do, sir. And first do the NEET PYQs. If you are thorough, then go for INSET PYQs. Otherwise, not needed. Right? 1 or 2 years of INSET kar loge to better hai. 1 or 2 papers, not years. 1 or 2 papers of recent INSET ka kar loge to better hai. But in covering INSET PYQs, not being thorough in NEET PYQs is not a wise idea. समझो, cover करना is not our aim. Covering the content is not our aim. Right? Solving the PYQs is not our aim. After solving the PYQs, if you don't have confidence that you are thorough with the PYQ topics, what is the use of solving the PYQs? यार क्वेश्चन पूछो अपने आप को. राइट, स्टूडेंट्स बोलते हैं सर 3 साल का 5 साल का मैंने कर लिया सर, सर सारे क्वेश्चंस कर लिए, सारे कर लिया सर. कुछ पूछता हूँ 2 यार, हे नहीं सर यार कर लिया, आंसर कर लिया, आंसर करो. नहीं सर, but what is this? You have done it, you're not confident, and that's why your performance is poor. You have thought कवर कर लेगा तो एक बार पढ़ लूंगा तो हो गया, कवर हो गया तो. यार कवर होने से नहीं होता है. Covering content is not our aim. After covering, you should be thorough. Ask yourself after covering, am I thorough with these PYQ topics? Any question going to come from this PYQ topic, am I able to answer? Yes. So then you can go for next 2 years of the NEET papers, INSET papers, everything. Otherwise, first what I suggest you is stick to 3 years PYQ topics of the NEET. 3 years PYQ topics of the NEET. Once you are thorough, add 2 more year papers. And once you are thorough, add 2 papers of INSET. Then it is a step-by-step process. If you do everything at once, and if you remember nothing, and if you don't have confidence that you can answer from the PYQ topics, it is of no use. And I know for a student, it is very difficult to identify PYQ topics, even if you see PYQs. And it is very difficult for a student how much to read in the topic, what is the exact topic, what is the subtopic, what is the main topic, how much to cover. And that's why DBMCI have planned these sessions. Right, so that students will come to know which are the important PYQ topics, how much to read, how much to settle. But still, yeah, DBMCI, we faculties, all of you are going to help you. We are here to help you. But ultimately, who has to do it? You has to do it. If you're not planning, if you're not making a plan for yourself, then all these things, they help you, but they're not going to, right, get you the PG seat unless until you're not going to plan better. Unless until what are you reading if you're not reading thoroughly. So last sentence बोल के मैं खत्म करके जाना चाहता हूँ. सुन लो, very important session, very important sentence. Right, students will tell FOMO, fear of missing out. Sir, somebody is doing that, somebody is doing this, somebody is doing that. Sir, fear of missing out. The question is, do you have any fear of the things what you have covered so far and you're not confident? Do you have the fear of all those things what you have covered so far and you're not remembering anything. You have the fear of those things which you have covered so far and not able to answer questions from the topics if comes. And you have the topic of the things what you didn't cover, what your friend is covering. Salute, man. What is this? Fear of missing out. Students are having the fear of the things which are not covered, which they didn't cover, which their friends are covering. And these students, they don't have the fear of the things they covered and they didn't cover it thoroughly. They covered and still they're not able to answer the questions from those topics, and they covered, they're not remembering anything from the topics what they covered, and they are worried about the topics which they didn't cover. Man, this is the foolishness. Man, behave, matlab you are a mature person. Behave like a mature person. Right? Fear of missing out. No, isko ganti बांध के फेंक दो कहीं पे. Right? Pack. Sir, put the fear of missing out in some pocket and pack it up and throw it out. First, develop the fear of the things which you have covered but not thoroughly. Usko thorough karo. The things which you have covered not remembering. Put the efforts to remember. The things which you have covered and not able to answer right. कवर करने से सीट नहीं मिलेगी यार. कवर करने के बाद उस टॉपिक से जो भी क्वेश्चन आएगा उसका आंसर सही करने से सीट मिलेगी, है ना? Covering the topic is not the thing which guarantees you the seat. After covering the topic, you have to answer the question right from the topics, then you are going to get the seat. So when you cover the topic, sir, cover it thoroughly, cover it in such a way that you remember, right? And cover in such a way that you can answer the questions in the exam. If not, see what is the mistake you're doing in your preparation, correct it, rather than covering more and more, new and new, doing something else. Remove the fear of missing out, and remember, the more you read, the more you get confused. The more you read, the more you get confused, and more you forget. Whether you will agree or not with me. यार बोलो यार, agree करोगे या नहीं? The more you read, the more you forget, the more you get confused. Agree करोगे या नहीं? तो करना क्या है सर? ज्यादा नहीं पढ़ना है नहीं बोल रहा हूं यार, राइट? कम पढ़ो, ज्यादा रिवाइज करो. The less you read, the more you revise. The less you read, the more you revise. The more you revise, the more you understand, and the more you remember, right? The less you read, the more you revise. The more you revise, the more you understand, the more you remember. Will you agree or not? सर इसका मतलब बोल रहे कम पढ़ो नहीं. First, prepare for the important topics. Revise them repeatedly. कब तक revise करना है? जब तक you get a confidence, I am thorough with all the important topics. And जब तक you're not answering all the questions right from the important topics. Once you have achieved this stage, then go for less important topics. Read them thoroughly. And if you're answering questions right, then go for the rare topics. राइट? ये छोड़ के सब पढ़ते रहते हो यार, इंपॉर्टेंट टॉपिक्स भी पढ़ते हो, लेस इंपॉर्टेंट भी पढ़ते हो, रेट टॉपिक्स भी पढ़ते हो. आजकल तो बच्चे अनइंपॉर्टेंट टॉपिक्स भी पढ़ते हैं यार. सल्यूट यार, राइट? कुछ तो दिमाग यूज करो यार. बोलो यार, God has given us brain to use, and exams are also test how you use your brain in the exam. Use your brain. It's not like just reading everything. याद रख लो यार, toppers, they won't read everything. If they read everything, they can't be the toppers. They plan better, they plan smart. They will decide what to read first, what to read next. Whatever they read thoroughly. Then only they go for the next things. If they are not thorough, they won't go for the next things. Right? If you do these things, you are also the toppers. Right? थोड़े की पॉइंट्स, गोल्डन वर्ड्स मैंने बताए अपने. इसको मैं बोलता हूँ एनकेपीस मतलब नसीर्स की पॉइंट्स. ओके, पहले बहुत बताता था, अभी सोशल मीडिया में उतना एक्टिव नहीं रहता हूँ यार. आई एम नॉट दैट एक्टिव इन सोशल मीडिया. ओके, न्यूली आई हैव ओपन माय इंस्टाग्राम अकाउंट आल्सो. अभी जस्ट 2 months back I have opened the Instagram account. Right? You can join me in Instagram account also. Same name, Dr. Blueprint. I will come up with more. I will be very active in Instagram in future very soon. Dr. Blueprint Instagram. Right? Very new to Instagram, but I will come up with very good videos, important topics, important preparation points, right? And songs also, right? Related to microbiology, right? Right? So Blueprint, Dr. Blueprint Instagram, right? Telegram be Dr. Blueprint. Search karo. Right? I will come up with very important, very necessity videos and reels and the clips. Right? See, there is one thing in me. What is that? I never discuss any nonsense things because we don't have time to discuss sensible things, right? अभी मैंने जो बताया उसको मैं बोलता हूँ NKPs. NKPs means Naseer's key points. Naseer's key points. Right? 3 years back when I started, when I joined Bhatia, first class in Bhatia, so I used to tell many NKPs. Now I have stopped. I'm not that active in social media because my life is very busy. That's why. But here onwards, I will take out time for the social media so that I can interact with the students. But what are the NKPs I have given? So first NKP, too much of too good becomes too bad. Everything there is a limit. You have to understand your limit. How much to read, right? How much time to revise? How much questions to do? If you do more questions also, you're compromising the time on revising notes, right? That is not accepted. If you revise more notes also, you're not solving questions. That is also not accepted, right? How much to time to give notes? How much to time to give solve questions? Now all toppers, they say 80-20 rule. सारे टॉपर्स बोलते हैं 80-20 rule. What is 80-20 rule? Sir, 80% of the time to revise notes, 80% of the times to revise notes, 20% of the times to solve questions, 20% of the time to solve questions. This is 80-20 rule, what toppers they say. From past 7 years I'm taking interviews, right? Every topper has said the same thing. How much time to give for which thing, that is important. First what subject to read, next what subject to read, next what to read. In every subject, first important topics to read, then less important to read, then rare topics to read. And unless until you are not thorough, you should not go for the next topic. So remember the first NKP, what I told you, too much of too good becomes too bad. Second NKP, if you read more and more and more, you forget more, you get confused more. That's why stick to important topics. Revise more and more and more. The more you read, the more you revise, the more you understand, and the more you remember. So read important things and revise more and more and more, right? That is the second NKP what I told, right? Step by step process. And third वाला कुछ बताया था, भूल गया यार, right? लेकिन जो भी मैंने points बताया, हाँ, third is FOMO. Then remove the FOMO को एक कंटेनर में डाल के पैक करके फेंक दो, right? Fear of missing out. तुम्हारा फ्रेंड कुछ भी पढ़ने दो, कुछ भी कोर्स करने दो, यार पहले आपने जो किया है उसको अच्छे से पढ़ लो यार, जो नहीं किया है उसके बारे में बाद में सोचो यार, जो कर रखा है अभी तक, जो कर रखा है उसको अच्छे से कर लो. एंड आई नो दिस इज नॉट द टाइम, this is not the time even to do the things, matlab this time is not sufficient even to do the things thoroughly what you have done so far, because you have done so many things that you can't do it thoroughly now in such a short time, because NEET is very near. And that's why what I'm telling is, whatever you have done in that, be thorough with the important topics. अभी तक आपने जो कर, सी दिस इज नॉट द टाइम टू डू समथिंग न्यू. कुछ भी नया नहीं करना है, कुछ भी नया कोर्स, साइड कोर्स, छोटा कोर्स, स्मॉल कोर्स, कोई भी इंस्टीट्यूट से कहीं से भी नहीं करना है. This is the time, whatever you have read, you have to be thorough with that. And I know you have read a lot and you don't have the time to go be thorough with all those things. And that's why these sessions, DBMCI sessions, which are coming here to show you, and these are the important topics, these are the PYQ topics. At least you be thorough with this. If you ask me only with this can we get the seat, yeah, only with this, right? It will help you, it will increase your chances to get the seat, but only with this you get the seat. मतलब आप चाहते हो कि 3-3 घंटा पढ़ के 19 सब्जेक्ट सीट ले लो, ऐसा थोड़ी हो पाएगा. But what we are telling is, whatever you have read so much. If it is not possible to read and revise and remember everything, whatever you read among that, at least you remember this. This will increase the chances of getting a seat in the NEET PG. We are here in your bad situation to increase your chances of getting a PG seat in the upcoming NEET exam. So this was the aim of these sessions. Hope you loved my session, and I will guarantee you you're going to love all the upcoming sessions. With that guys, अच्छे से पढ़ लो. My blessings are there always with you, right? ನಮ್ಮ ಆಶೀರ್ವಾದ ನಿಮ್ಮ ಜೊತೆ ಇದೆ ಆಯ್ತಾ. ಎಲ್ಲರೂ ನನ್ನೈತೆ ಪಡಿಕೆ ನಮ್ केटो, right? So सब लोग अच्छे से पढ़ लो. Read well and revise more and more and more. Read well, revise more and more and more. Prepare well, prepare smart. With that, all the best. Good night. Bye bye. See you.